evening, everyone. A very warm welcome to the second day of Swasthyabodha National Seminar presentation. We are delighted to continue our academic section today with the same enthusiasm and scholarly spirit that marked yesterday's presentation. We look forward to another series of insightful and well-prepared presentation from our participants. Before we begin the scientific section, I would like to officially hand over the coordination of today's presentation schedule to Dr. Sabi.
Thank you, Doctor, and good evening to one and all. On behalf of Ayurapta organization, it's my great pleasure to warmly welcome each one of you to the second day of Swasthyabodha National Seminar presentation. Ayurapta is a dedicated research organization committed to academic excellence, clinical enrichment, and the advancement of Ayurveda through structured and systemic learning platforms. Our vision is to foster meaningful academic discussions, promote research orientation, and provide scholars and practitioners with opportunities to present their knowledge at both national and international levels. Over the years, Ayurveda, in collaborating with Samiksha organization, has successfully organized numerous and national and international seminars, certificate courses, and interactive academic sessions across various Ayurvedic specialties. These initiatives have consistently aimed at bridging classical knowledge with clinical application. Our major academic initiatives include National Seminar Series on Clinical Neurology, Pediatric Neurology, Neurodegenerative Diseases, and Acute Stroke Management in Ayurveda, academic discussion on Rasaushadis in Vadavyadi, and the role of Shodhana and the Shamana Chikitsa in neurological disorders, webinar series on principles and practice of gynecology and obstetrics covering dysmenorrhea, fibroids, leukorrhea, PCOD, female infertility, and endometriosis. Specialized programs on anorectal disorders, including Sharakarma, Sharasutra therapy, Fisher, Fistula, Arshas, and Bhagandara management. National seminars on lifestyle disorders such as obesity, metabolic syndrome, thyroid disorders, hypertension, prameha, and sleep eating, which are certificate course on medicinal preparation and women's health care, as well as international seminars on Kriyakalpa and OP level procedures. Through these academic ventures, Ayurveda has constantly created platforms for knowledge exchange, clinical experience sharing, research presentation, and professional development. As we begin the second day of Swasthyabodha National Seminar presentation, I extend a special and heartfelt welcome to all those who have stood with us in organizing and supporting this academic initiative. Your cooperation, encouragement, and active participation have made this seminar a meaningful success. I would like to express my sincere gratitude to our respected panel members who have worked tirelessly day and night to verify the papers, evaluate the presentations, and maintain the academic standards of this program. Their dedication, time, and expert guidance are deeply appreciated. I also extend our sincere thanks to the principals and professors from various Ayurveda colleges who supported this initiative and encouraged their students and colleagues to participate. Your institutional support and academic trust have significantly contributed to the success of this seminar. A special appreciation goes to all our presenters. Your commitment to research, preparation, and confident presentation reflects the growing academic strength of our Ayurveda community. The topics presented are highly relevant, research oriented, and clinically meaningful. I am also blessed to inform you that recording of a previous seminar are available for those who wish to revisit or access them for academic enrichment. As time is limited, without further delay, let us proceed to the first presentation of today's session and continue this journey of academic excellence with enthusiasm and professionalism. Thank you all once again for being part of the Swasthyabodha 2026. First, I would like to invite Dr. Ajay Vasanta Marge for the first paper presentation. I would like to invite Dr. Ajay Vasanta Marge for the first paper presentation.
Respected chairperson, honorable judges, respected teachers, and my dear colleagues, I am Dr. Ajay Margi, MD Gayatri, and today I am presenting my review topic on the chemicals used in hair shampoo and hair care product causing hair fall and risk of cancer. The modern cosmetic industry frequently employs synthetic chemicals in hair care products such as shampoos, conditioners, and hair dyes. Many of these are associated with adverse health effects. Among the most concerning are ingredients like sodium lauryl sulfate, parabens, formaldehyde, phthalates, which are linked to hair fall, scalp irritation, endocrine disruption, and even carcinogenicity. From an Ayurvedic perspective, this substance may be interpreted as dosha, which can be termed as chronic low-grade toxin that accumulate over time and disturb dosha and dhatu balance. This review paper explores harmful chemicals used in commercial hair care products, their toxicological impact, and Ayurvedic alternatives. Hair fall carcinogenic chemicals, shampoo toxins, dosha, Ayurvedic toxicology, SLS, parabens, hair care products, Kesha. Introduction. The global cosmetic industry has experienced remarkable growth in hair care products such as shampoos, conditioners, hair colors, and serums. While marketed for nourishment and shine evidence highlight hidden toxicity and long-term adverse effects, including hair fall and possible carcinogenic risk. In Ayurveda, hair kesha is considered a byproduct of Vasudhatu. Its health depends on balanced doshas, especially Pitta and Vata. Exposure to external toxins through chemical-based hair products disturb this balance, resulting in Keshapatan, hair loss, Khalitya, baldness, and Palitya, premature graying. Material and methods. This review utilizes data from the PubMed, ResearchGate, WHO, Cosmetic Ingredient Review reports, IARC monographs, Ayurvedic reference including Charak Samhita, Sushrit Samhita, Bhav Prakash, Rasita Ranjani, ingredient level of commercial hair products were also analyzed. Common harmful chemicals and effects. Sodium lauryl sulfate, scalp irritation, hair fall, and dermatitis. Sodium laurate sulfate, oil stripping, possible one for dioxin contamination. Parabens, endocrine disruption, estrogen mimic, possible cancer link. Formaldehyde, group 1 carcinogen. Phthalates, hormonal disruption, reproductive toxicity. Coal tar dyes, cancer risks. Triclosan, thyroid disruption, possible carcinogen. PEGs, possible contamination with carcinogenic compound. Silicones, follicle clogging, and hair weakening. Mechanism of hair fall. Disruption of natural scalp oil, follicular oxidative stress, harmful disruption, chronic scalp inflammation. Carcinogenic potential, formaldehyde, proven human carcinogen, parabens found in tumor, coal tar linked to cancer in industrial exposure, contaminants like 1,4-dioxane and ethylene oxide, probable carcinogens. Ayurvedic perspective. These chemicals resemble dusha, chronic toxins that accumulated and disturb dosha and dhatus. This leads to Khalitya, Indralupta, and Palitya. Ayurvedic detox and treatment, Shodhana and Shamana therapy, herbal oil like Bhimraj tea, Bhingadi Tela, herbs such as Haridra, Manjishta, Amla, Brahmi, Betamasi, and Nimba. Conclusion, chemical-based hair products may contribute to hair fall and carcinogenic risk. Ayurveda offers safer natural alternatives like Ritha, Shikakai, and Amla. Public awareness and use of herbal hair care can promote safer and sustainable health. Recommendation: avoid parabens, sulfate, and synthetic fragrance. Read label carefully. Use Ayurvedic or herbal alternatives. Promote research in Ayurvedic detox service. Reference taken from IRC Monographs 2012. Cosmetics Ingredient Review Reports. Darby PD, Harry PW 2008. Charak Sayita, Sushruत Sayita. Bhav Prakash, Ayurvedic Formulary of India. Thank you.
Thank you, Dr. Ajay. Thank you for the insightful presentation. Next, we go to the enteric fever related paper presentation. I would like to invite Dr. Krishnkant Ravindra Gaikwad for the paper presentation on the topic enteric fever.
All of it. I am Dr. Krishnkant Gaikwad, Ramnikamaravatya, third year. I am Sumativesha Ayurvedic College, Sani Guruji Arogya Kendra, Malwadi Health Company. Today I am presenting a paper on enteric fever. First we see the introduction. Typhoid fever is an infectious disease. Usually starts in the gastrointestinal tract. It's a acute generalized infection of the reticuloendocrine system. It occurs mainly in rainy season. It contributes 20% of all fevers in hospitalized children. There are 2 to 3 million cases of enteric fever in India annually. Enteric fever remains endemic in many developing countries. Second point, we see the etiology. Salmonella typhi in 80% of all cases, and Salmonella paratyphi in 20% of the cases. Salmonella typhi is gram-negative Flagellar bacteria. Next, we see the transmission. Typhoid mainly spreads from fecal-oral route, continuing from and water. Human from the main reservoir. The inflammation time 7 to 14 days. Next point, we see the pathophysiology. Overall entry of Salmonella typhi through the ingested food. Enterocytes line terminal ileum. Then bacteria goes to Pear's patch and resident macrophage. Then goes to mesenteric lymph nodes. Primary bacteremia occurs in bloodstream, which is a asymptomatic stage. Ceiling of the reticuloendothelial system, multiplication of the Salmonella typhi in liver, spleen, and bone marrow. Pear's patch is re-exposed to the typhi via bile, which is also called as a secondary bacteremia. Widespread dissemination occur and onset of the clinical symptoms. Now we see the clinical features. High-grade fever in 95% of the patient, coated tongue in 76% of the patient, anorexia 70% of the patient, vomiting in 39% of the patient, hepatomegaly, diarrhea in 37% of the patient, abdominal pain in 21% of the patient, pallor, splenomegaly, constipation, headache, jaundice, obtundation, intestinal perforation, ileus. Now we about symptoms. We divided into the week-wise symptom. In first week, staphylococcus pattern of the fever is there. That is fever without focus. Diarrhea, which is a piece of diarrhea, green false swing stool. Headache, vomiting, anorexia may occur in first week. And in second week, typhoid bronchitis, which is also called as propionic typhoid, hepatosplenomegaly, rose spots may be seen in second week. Relative bradycardia also seen in second week. And in third week, abdominal complications like distended abdomen, intestinal hemorrhage, intestinal perforation also occur. Now we can now we go in clinical diagnosis. Clinical diagnosis is by mainly prolonged high-grade fever without no focal infection, no stools, relative bradycardia, coated tongue, headache, brutal fever, tympanic abdomen, pallor, and look for rose spots, hepatosplenomegaly. These are the diagnostic features of the typhoid fever, which is mainly occurs in 5 to 15 years of the age. In investigation hemogram, there is leukopenia will be there, eosinopenia, neutrophilia, thrombocytopenia may also be there. Viral test, which is done after the 7 days of infection, actually, most of the general practitioners do in 3 to 4 days, which is totally wrong. So, viral test is done after the 7 days of infection, mixing the patient's serum with inactivated salmonella antigen and serial dilution of the patient serum are made. Viral, when we say viral positive, 1 has to 160 titer and above. This non-specific test, but it may be false positive also in malaria and recursive infection. Other tests to diagnose typhoid or test into first 2 to 3 days of the infection. Blood culture, which is a gold standard diagnosis of the typhoid fever, which also detects the sensitivity of the antibiotics, which is 90% sensitivity in the first week. Then we do CRP, high CRP differentiates enteric fever from the viral fever, especially dengue. USG abdomen pelvis may also be done to access the complication of the typhoid fever, mesenteric adenitis, to rule out perforation. Stool culture occasionally positive even during the incubation period. In last stage, we can do the bone marrow culture punch biopsy. The differential diagnosis of the typhoid fever, viral fever, dengue, malaria, bronchopneumonia, bronchitis, acute hepatitis, gastroenteritis, brucellosis, leptospirosis. The complications of the typhoid fever are intestinal hemorrhage, perforation, toxic myocarditis, encephalopathy, meningitis, pyelonephritis, jaundice, cholecystitis. Now we go into the treatment plans. The uncomplicated illness, that is at the opening level, first line antiviral is a cefixime. Normal dose of the cefixime is 8 to 10 mg per kg per day. But in typhoid, we give the double dose, that is 20 mg per kg per day 12 hourly. The The one alternative medicine for this infection is azithromycin. The normal dose of the azithromycin is 10 mg per kg per day, but in typhoid, we use the double dose that is 20 mg per kg per day, 24 hourly for 7 to 14 days. In severe illness, that is in the IPD patients, injection ceftriaxone, which is the first line antimicrobials in IPD patient, which can give by the 100 mg per kg per day 12 hourly. Alternative to the injection ceftriaxone, we can use injection azithromycin, which is a monoactive antibiotic, 150 mg per kg per day, 8 hourly. Now we see the empirical therapy in our typhoid, that is enteric fever. Third generation cephalosporins, which stops the bacterial cell wall formation. Cefotoxin, we also can use 100 mg per kg per day BD or ceftriaxone 100 mg per kg per day. It is effective even for the EMDR type, that is multi-drug resistant typhoid. XDR typhoid, extremely drug resistant typhoid. Azithromycin is a drug of choice, sensitive to carbapenem, meropenem, that is 40 mg per kg per dose. That is in XDR type, you can use azithromycin and meropenem. In severely ill patients with shock, obtundation, stupor, or coma, we use the dexamethasone 3 mg per kg per dose initially, followed by 1 mg per kg per dose 6 hourly. Prolonged use of the steroids can increase the relapse rate. The aminoglycosides like amikacin have no role in the management as their site of action is extracellular, with salmonella is an intracellular organism. The relapse of the enteric fever is due to optimal duration of the antimicrobial therapy is at least for 10 to 14 days. The relapse of the enteric fever is due to the incomplete course of the antimicrobials, which is one of the main reasons. Rate of the relapse is higher with beta-lactam, cefixime or ceftriaxone as compared to azithromycin. The prevention of the enteric fever is maintain hygiene and sanitation, chlorination and purification of the water, avoid consumption of street food, early diagnosis and treatment, proper hand wash, clean food, boiled filtered water, social distancing, adequate nutrition and vaccination. In vaccination, we use two vaccines, typhoid conjugate vaccine and typhoid polysaccharide. Now we can see the difference between the typhoid conjugate vaccine and typhoid polysaccharide vaccine. Efficacy of the typhoid conjugate vaccine 90 to 95% and polysaccharide 60 to 65%. The main difference between the typhoid conjugate vaccine and polysaccharide vaccine is the polysaccharide sugar joined to the carrier protein like tetanus, diphtheria, toxoid, and in typhoid polysaccharide vaccine it contains only polysaccharide of the bacteria. Uh, Now we can see the typhoid vaccine dose and set. 0.5 IM interlateral aspect of the thigh. The typhoid conjugate vaccine single dose is insufficient, but typhoid polysaccharide vaccine it can be revaccinated every 2 years. Thank you so much.
Thank you, doctor. Thank you for the paper presentation. And one more poster presentation is there on the topic a golden sun breastfeeding in the first hour.
Hello, good evening all of you. I am Dr.Krishnkant Gaikwad, Kumar student Ma'am Sumati Shah, Ayurvedic College, and Sawlani Arogya Kendra, Malwadi Club Circle. My poster name is Golden Start Breastfeeding in the first hour. Why the first hour matters? Here we can see the first hour after birth is known as a golden hour. The breastfeeding in the first hour regulates the baby's body temperature, which prevents hypothermia in the baby. Breastfeeding in the first hour establishes emotional bonding between the mother and child. As in Ayurveda, Vatsalya is important, which is told in the Kashyap Samhita. Initiates a successful breastfeeding rather than formula feed. We initiate breast milk in a first day so that emotional stability between the mother and child will be established. Calm mind, activation of oxytocin and prolactin pathways improves the milk synthesis. These are the benefits of first hour breastfeeding. Then we can see breastfeeding in the first hour. What benefits are for the baby and what for the mother? First, we see Benefits of breastfeeding in the first hour for the baby. Immune boost gain of acids, cholesterol, brain development, emotional bonding, stable vital signs, better breastfeeding. For the mother, it stimulates the milk production, early sucking, tetanus being leading, reduces postpartum bleeding, mental well-being, promotes maternal relief. Hence, external breastfeeding for first 6 months with adequate birthing. This is also important. Now we see the organ in the colostrum. Colostrum is often called as a liquid gold. Its color is thick and yellowish. Rich in immunoglobulins, especially IgA, white blood cells, proteins, vitamins A and E. It acts as a natural vaccine, coating the baby's gut and defending against infection. In present era, most of the mothers give formula feed to the mother. But formula feed doesn't digest properly to the babies, and it becomes very not easy to digest to the baby. Hence, I advise all mothers to give breast milk to the baby up to 6 months, not formula feed. Thank you so much.
Thank you, doctor. Thank you for the detailed paper and poster presentation. Next, we go to the another paper presentation. I would like to invite Dr. Adinath Vishnu Vetal for the paper presentation on the topic Applicability of virechana karma in Ascites, jalodara. I would like to invite Dr. Adinath Vishnu for the paper presentation.
Hello everyone, I am Vedya Adinath Vishnuveta, PG scholar from Department of Kaya Chikitsa, Yashwantrao Chavan Ayurvedic Medical College and Hospital, Chhatrapati Sambhajinagar. Today, I will be presenting a topic on applicability of virechana karma in ascites, that is jalodara. The topic is also guided by Vaidya Arshad Khan Patan sir, Associate Professor, Department of Kaya Chikitsa, Yashwantrao Chavan Ayurvedic Medical College and Hospital, Chhatrapati Sambhajinagar. In Ayurveda, we correlate ascites with jalodara, which is the most advanced stage of Udara Roga. In Samprapti of Jal Udara, Agnimandya and Ajirna are the two main important factors which lead to the accumulation of mala and taud, that is fluid, between the twacha and amansa, which leads to the increase in abdominal girth and fluid accumulation. The golden rule stated by Acharya Charaka in Chikitsasthana for the treatment and the management of ascites, that is jaludara, is nityam virechayat. The patient of jaludara should be administered purgative therapy every single day. Mechanism of action according to Ayurvedic point of view. The virechana does the work of Srotodushti, that is clearing the obstructed channels. The Ambova Srotasa and Swasthyabodha Srotasa are being cleared with the help of virechana. Virechana also does the Vatanulomana, correcting the natural movement of Apanavayu, which is essential for fluid extraction. Virechana also does Pitta Shamana. It balances Yakruta, the primary site of the Pitta. According to modern physiological view, osmotic gradient purgatives increases the osmotic pressure in the intestinal lumen, drawing the fluid from the peritoneal cavity into the gut for extraction, thus reducing the volume of the ascitic fluid. The purgation therapy also reduces the portal venous pressure. The anti-inflammatory the virechana karma also has anti-inflammatory action. It stimulates the enteric nervous system to release neuropeptides that help in reducing systemic inflammation. Virechana dravyas used in ascites. The choice of drug depends upon the patient's kostha. Most commonly used primary drugs are Trivrita, which is considered as the best and easy for purgation therapy. Kutiki acts as a potent hepatoprotective and Bhaidaniya drug. Tela, often given with milk for Vata dominance ascites. Common formulations used are Trivrit Avaleha, Icha Bedi Rasa, Arogyavardhini Vati. Evidences from the research also support the use of the virechana karma in ascites. Serum electrolyte stability. As the modern diuretics cause electrolyte imbalance, the research supports that the virechana karma does not cause the electrolyte imbalance if proper sansanjana karma is being followed. The research published in JAIM and IU journal reports there has been virechana karma has shown significant effect for reducing the abdominal girth and body weight. LFT levels, that is the serum bilirubin, and SGOT SGPT levels are reduced markedly after giving nitya virechana for about 30 days. Patients refractory to modern diuretics often show diuretic sensitivity after a course of virechana. Modern day application. Virechana can be used along with salt restriction and fluid restriction for the management of ascites. Nitya virechana versus classical virechana. In ascites, nitya virechana, that is mild to moderate purgation, is preferred over one-time heavy purgation to prevent sudden hypovolemia. In conclusion, we can say that virechana karma is not just a purgative, is not just a laxative therapy, but a systemic detoxification that addresses the root cause of the fluid accumulation. Thank you.
Thank you, Doctor. Thank you for the insightful presentation. Next, I would like to invite Dr. Jyoti Jawahar Sawlani for the paper presentation on the topic Role of Srotodushti in Pathogenesis. I would like to invite Dr. Jyoti for the paper presentation.
Role of Srotodushti in pathogenesis. Myself, Dr. Jyoti Sawlani, PG second year student from Ayurvedic Medical College, Mumbai. Introduction. Srotas represent both the structural and functional unit of human body and play a crucial role in the maintenance of health as well as development of disease. According to Ayurveda, Srotomayam hi Purusham, meaning that the human body is essentially a system of channels. Disease manifests when there is impairment in the normal functioning of these channels, that is Srotas. Even minor disturbances, whether structural or functional, sudden or gradual, can disrupt the physiological activities carried out through Srotas, ultimately which leads to pathological conditions if not corrected in time. Therefore, restoration of the integrity of Srotas is fundamental for regaining normal health. The classical statement Srotansi khalu parimana apadyamananam dhatunam abhivahanam indicates that Srotas serves as pathways for the transportation and transformation of dhatus as they undergo metabolic changes forward their target sites. Another reference, Yavantah Purusho Murtimanto Bhava Vishesha Tavanta Asmina Srotasam Prakara Vishesha highlights that the diversity of structures and functions within the body corresponds to the multiplicity of Srotas. In general usage, the term Srotas denotes the macro and micro channels or pathways operating throughout the organism. Thus, Srotas can be understood as dynamic pathways that facilitate movement, filtration, secretion, and transformation of substances necessary for sustaining life. Concept of Srotas. The term Srotas is derived from Sanskrit root word sru, which means that to ooze, to permeate, to flow, or to move. Therefore, Srotas refers to the channels or pathways through which various substances are secreted, transported, circulated, and metabolized in the body. According to Ayurveda, the human body is described as Srotomayam Purusham, meaning that it is fundamentally composed of a network of channels. These channels form a complex internal transport system responsible for maintaining physiological function. Srotas include all kinds of passages, gross as well as subtle, visible as well as microscopic, that enable the movement of nutrients, waste products, and vital energies. A classical text describes Srotas using various synonyms, that is Sira, Dhamani, Rasayani, Nadi, Marga, Sharira Chidra, Ashay, and Niketa. Srotas represent the body's multidimensional channel system responsible for internal communication, metabolism, and homeostasis. Proper functioning of these channels maintains health, while their impairment, that is Srotodushti, leads to disease manifestation. Here are the functions of Srotas. So first function is nourishment of dhatus, that is sequential tissue nutrition. Second is transportation, that is vahana karma. Third is regulation of dosha, dhatu, and malas. Fourth is internal communication system. Another is growth, development, and repair of tissues. Another function is elimination of waste products. Also, it has role in health and disease integrity. And the last function is regulation of dosha balance. Now, what is the role of Srotodushti in pathogenesis? First we see what is Srotodushti. So, Srotodushti is structural and functional derangement of Srotas, which is crucial factor in the development of disease. So, we see how pathogenesis occur. After Nidana Sevan, Nidan is the first, Nidan is that the pathogenesis begins. Then doshas get aggravated, and aggravated doshas circulate through the body via srotas, that is prasar stage. And then it encounter a region of weakness or defect, that is khavegunya, in a particular srota. They localize there and interact with dushya, that is tissues. And then it marks the actual beginning of disease formation, that is sthano sanshraya. So what Srotodushti provides is first the site for dosha lodging, second is the environment for dosha dusha samurshana, and another is the basis, it has the basis of manifestation of clinical symptoms, and it has the role in progression of shatakriya kal. Hence, Srotodushti is bridge between dosha imbalance and overt disease. What are the features of Srotodushti is Charak Vimanstan chapter 5th describe that Ati Pravrutti Sangova Siranam Granthe Apiva Vimarga Gamanam Chapi Srotasam Dushti Lakshanam. Here 4 Dushti Lakshan of Srotas are mentioned. First is Ati Pravrutti, that is abnormally increased activity or flow from a Srotas. We can give example that Bahumutrata in Prameya and Ati Dravamala in Atisar. We can see that Ati Pravrutti of doshas. Second is Sangha, that is blockage or hindrance in Srotas. Example is Mutakrucha due to obstruction in Mutravara Srotas and Sveda Avarod in Jwara. Third is Sira Granthi, that is Granthi is thickening or nodular formation or structural deformity in the channels. Examples is Granthi or Charmakila. Vimarga Gaman, then fourth is Vimarga Gaman. It occurs when substances move through abnormal channels instead of their natural pathway. Example is fluid accumulation in tissues causing chauffeur. So the conclusion is Srotodushti is a central concept in Ayurveda pathogenesis, representing the stage at which functional disturbances evolve into disease. Maintenance of Srota's integrity ensures proper nourishment, metabolism, and elimination, while their vitiation leads to systemic imbalance. So, recognizing and correcting Srotodushti allows early intervention, prevention of chronic illness, and restoration of physiological harmony. Thank you.
Thank you, Dr. Jyoti, for the well explained presentation. Next, I'd like to invite Dr. Ranjita Shamsundar Masurkar for the paper presentation on the topic Concept of Matravat Ahara in Ayurveda. I would like to invite Dr. Ranjita Shamsundar Masurkar for the paper presentation.
Everyone, myself Dr. Ranjita Masurkar. I am PG scholar from Department of Savita and Siddhant, Podar Medical College, Mumbai. My topic is concept of Matravat Ahar in Ayurveda. Introduction. Ahar is considered one of the three pillars of the life, which we call Trayopastambha in Ayurveda. Among the various dietary principles explained in classical texts, Matravat Ahar holds significant importance in maintaining health and preventing disease. In Charaka Samhita, Sutrasthan Adhyay 5th Matrashiti Adhyay, Acharya Charak emphasizes that the quantity of food should be determined according to the strength of the Agni. He states that the food taken in appropriate quantity promotes proper digestion, maintains dosha balance, nourishes dhatu, and enhances bala, varna, sukha, and ayu. Conversely, improper quantity, that is either excessive or insufficient quantity of diet, leads to Agnimandya, dosha, vitiation, and various diseases. Thus, concept of Matravat Ahar is not merely about portion control but represents an individualized dynamic dietary principles based on Agni, Bala, age, season, and constitution. This concept remains highly relevant in present era of lifestyle disorders caused by improper eating habits. Firstly, we understand what is matra. In Ayurveda, matra refers to proper and safe quantity of food or medicine that can be consumed without causing harm. In Charak Samhita Sutrasthan 5th Adhyay, matra is explained as matra anapai parinam by Chakrapani, meaning the quantity that does not produce any adverse effect. Thus, matra is not a fixed measurement but an individualized quantity suited to one's digestive capacity. Also, in Charak Samhita Vimansan 2nd Adhyay Trividha Kukshi Vimanam, Charakacharya also said that while taking foods, the stomach, that is we call kukshi, should be divided into three parts. The person who fills stomach appropriately, first part with solids, second part with liquids, and third part keeps empty, does not suffer from diseases caused by improper diet. Importance of Trividha Kukshi is first, prevent Agnimandya, second, facilitate proper digestion, avoid Tridosha aggravation, and support Samyak Parinam, that is proper digestion. Practical understanding of this concept is portion control, avoidance of overeating, maintenance of digestive balance. It is direct application of Matravat Ahar. Factors affecting Ahara Matra. According to classical Ayurvedic texts, especially Charaka Samhita, Ahara Matra is not fixed and depend on several individuals and environmental Ahara Matra is not fixed and depends on several individual and environmental factors. First factor is Agni. It is the main determining factor. Strong Agni, the person with strong Agni can consume a large quantity of food. The person with Mandagni, smaller quantity of food is required. The person with Vishamagni, we can, according to their appetite, the food can be taken. Chakrapani stated that Ahara Matra Punha Agni Bala Pekshini. Second one is Bala. Individuals with good strength can tolerate comparatively more food. Weak or diseased individuals require lighter and lesser quantity. Third is Vaya, that is age. Generally youths have strong Agni, therefore they can consume more Matra. Children and old aged peoples have weaker Agni, hence reduced Matra is useful for them. Third one is Ritu, that is season. In Hemant and Shishir Ritu, Agni is strong. Here, therefore, higher quantity of food can be taken. In Varsha and Grishma, Agni is weakened. Hence, comparatively lesser amount of food should be taken. Fourth one is Prakruti, that is body constitution. Vata, Pitta and Kapha Prakriti. Vata Prakriti can have moderate quantity of food. Pitta Prakriti needs frequent diet but controlled quantity. Kapha Prakriti will require light and lesser quantity. Nature of food, Guru and Laghu Dravya. Laghu Dravya can be taken slightly more. Guru Ahar should be taken in smaller quantity. Benefits of Matravat Ahar. The benefit of taking food in proper quantity are clearly explained in Charaka Samhita and also supported by Ashtanghrudaya. Matravat Ahar helps in proper digestion. Food get digested in proper time. No formation of arm. Maintains Agni in balanced state. Maintains dosha balance. Do not disturb Vata, Pitta and Kapha. Prevent Tridosha Prakop. Maintains Prakriti equilibrium. Nourishment of Dhatu. Proper Rasa Raktadi Dhatu formation. Sequential nourishment of all Dhatus. Enhances Ojasa. Promotes strength and vitality. Charak mentioned that proper quantity of food promotes Bala, Varna, Sukha and Ayu. Prevent diseases. Avoids Agnimandya. Prevent lifestyle disorders. Reduces risk of metabolic imbalance. Provides lightness and comfort. No heaviness, no bloating, no lethargy. These are all the benefits of Matravat Ahar. Disadvantages of Amatravat Ahar. Amatravat Ahar refers to intake of food in improper quantity, that is either Heenamatra or Atimatra. Charak Sutra Sthan Adhyay 5th and Ashtanghrudaya Sutra Sthan Adhyay 8 already mentioned the Matravat Ahar. Disadvantage of having Heenamatra Ahar, that is we can call under eating. According to Vagbhat, it does not promote Bala, causes Vata Vruddhi, leads to Karsha, produces weakness and fatigue, and impair nourishment of Dhatus, which result in Dhatu Kshaya, reduce Ojas and early aging. Harms of Atimatra Vat Ahar, that is overeating. Charak and Vagbhat describe that excessive intake causes Agnimandya, leads to arm formation, produces Tridosha Prakop, causes Gaurav, Adman, Alasya, and serious consequences like Ajirna, vomiting, diarrhea, fever, and metabolic disorders. Vagbhat says that Atimatra aggravates all the three doshas. Conclusion of all of this is: eat according to your Agni, not according to desire. Quantity of food is as important as quality of food. Follow the principle of Trividha Kukshi. Fill the stomach properly, not completely. Avoid both undereating and overeating to maintain dosha balance. Matravat Ahar is a simple yet powerful preventive tool for sustaining health and longevity. Right quantity of food is the foundation of right health. Thank you.
Thank you, Dr. Ranjita, for the insightful presentation. And next, I would like to invite Dr.Shital Dnyanoba Kukade for the paper presentation on the topic Ayurvedic perspective on thyroid disorders. I'd like to invite Dr. Shital for the paper presentation.
Myself, Dr.Shital Dnyanoba Kukade, BMS MD scholar in Chikitsa Department at Institute Yashwantrao Chavan Ayurvedic Medical College and Hospital, Chhatrapati Sambhajinagar. Today I am going to present a topic on Ayurvedic perspective on thyroid disorder, which resembles to Galaganda and Agnimandya and integrative view. So thyroid disorders are common endocrine diseases affecting metabolism, growth and homeostasis. Globally, hypothyroidism affects about 4 to 5% of the population, while subclinical hypothyroidism ranges from 4 to 15%. In India, nearly 10 to 11% of adults and about 42 million people are affected, with higher prevalence in women. Although the thyroid gland is not separately or anatomically described in Ayurveda, though its clinical features resembles Galaganda, Gandamala, Agnimandya and Srotodushti. These conditions are understood through three-dosh imbalance, Agnimandya and Srotodushti, predominantly involving Kapha and Vata. With the rising prevalence and limitations of long-term conventional therapy, Ayurveda offers a holistic management approach through Nidan Parivarjan, Shodhan and shaman chikitsa with lifestyle modifications. Thyroid disorders are among the most prevalent endocrine diseases worldwide. So, thyroid disorders are common endocrine disorders which includes hypothyroidism, hyperthyroidism, goiter, autoimmune thyroiditis. The thyroid gland plays a vital role in regulating body metabolism through T3, T4, and TSH hormones. The prevalence of thyroid disorders, especially amongst women, has increased significantly. So, modern management often requires lifelong hormone therapy. Hence, there is need to explore Ayurveda's holistic and metabolic approach. There is no thyroid description directly in classic Ayurveda, but correlation with Galaganda Agnimandya made the Srotodushti kapha-vata imbalance resembles the thyroid symptoms. In Ayurveda, the symptomology and pathogenesis of thyroid disorders are based on these factors. So the central concept revolves around impairment of Agni, leading to systematic metabolic disturbances. Modern understanding of thyroid. The thyroid functions is regulation of metabolism, which influences fat, menstrual cycle, fertility, mood, and cardiac activity. In thyroid disorders, the pathology is in hyperthyroidism there is high metabolism, and in hypothyroidism there is low metabolism. So for hyperthyroidism, symptoms are bradycardia, brittle hair loss, cold intolerance, weight gain, menstrual irregularity, depression, swelling, sleep disorders, low blood pressure, and headache. For hyperthyroidism, there are symptoms like tachycardia, thinning hair, hot intolerance, weight loss, menstrual irregularity, bulging of eyes, tremors, sleep disorders, high blood pressure, and enlargement of thyroid gland. And concept of Galaganda in Ayurvedic classic references, in Sushruta Samhita there is mention in Nidan Stan, and in Charak Samhita there is mention in Chikitsa as a swelling in the neck region caused predominantly by kapha and vata dosha, which refers to the Galaganda. The classical features such as grevashrot and granthi formation show strong clinical resemblance with goiter and certain thyroid enlargements along with mandagni and heaviness. Agnimandya is considered the fundamental pathology in most hypothyroid-like conditions due to impaired Dataragni, and Dhatavagni also becomes weak, leading to arm formation, which is toxins. These arm increases kapha and causes Medha Dhatu Dushti and Srotodushti, which blocks the channels, that is obstruction in the pathways, so it leads to the slow metabolism, which closely resembles with the hypothyroidism. In Samprapti, the major causative factors include for the Nidan are Snigdha and Guru Ahar, Divaswap, lack of exercises, chronic psychological stress, Avayam. These are the factors as a Hetu in hypothyroidism or hyperthyroidism. These factors promote kapha vriddhi and Agnimandya, thereby initiating pathological cascade leading to thyroid dysfunction. In Samprapti Ghataks, for hypothyroidism, kapha and vata are predominant dosha, while in hyperthyroidism stage, pitta along with vata dosha. The main doshas involved are Medha and Rasa Dhatu. The affected Srotases are Rasa Dhatu, Rasavaha and Medoha, and Mandagni with arm presence forms the core pathology. For hypothyroidism, clinical features like weight gain resembles with Medha Vriddhi, lethargy with Kapha Vriddhi, cold intolerance with Vata and Kapha Dosha, constipation leads to Vata Dushti, depression leads to Manohar Srotodushti. For hyperthyroidism, Pitta and Vata dominance leads to the weight loss because of the Dhatushay, irritability due to Pitta Vriddhi, tachycardia due to Vyanavata Dushti, excess sweating due to the Pitta Prokop. Here the metabolic state resembles Tikshna Agni rather than the Mandagni. For Chikitsa Siddhanta for thyroid disorders, the line of treatment focuses on Agni Deepan, Ampachan, Kaphameda Shaman, Vatanloman, Srotoshodhan, Rasayan, that is long term stability. The aim is to correct the root metabolic disturbance rather than only suppress symptoms. For internal medicines, for thyroid hypothyroidism, Kapha Vata dominant condition, Deepan Pachan, for that Tikatu Churna, Chitrakadivati and Panchakol Churna can be used. For Medahar and Kapha Shaman Chikitsa, Kanchanar Gugul, for glandular swelling, Orunadipat, for Kaphameda reduction, Trifala Gugul for obesity, that is Medha reduction, and Punarnava Mandur in idiomatic conditions can be used. For Agni strengthening, Lashun, Shunti, Jira Siddha Takra used. In hyperthyroidism, for Pitta and Vata dominant condition, in Pitta Shaman Chikitsa, Praval Pishti, Mukta Shukti Bhasma, Shatavari, Guduchi can be used, and for Vata Shaman, Ashwagandha, Brahmi, Yashti Madhu can be used. Panchakarma plays a vital role in thyroid disorder treatment. For that, virechana, Mrudu virechana can be done with Trivrutta Leha, Avipattikar Churna, Gandharvastadi Tel, Aragvat Phalamajja, and in Kapha and Pitta condition, Trivrutta and Draksha combination can be used. For Basti, Anuvasan Basti and Nirva Basti, both performed with Chirapala Tel, Sahachar Tel, Dhanvantaram Tel, Dashmulkat, Varunadikat, and Punarnavadikat, Basti can be done. For Panchakarma approach, Udvartan and Nasya plays a vital role in treatment. Best for obesity are Trifala Churna, Yava Churna, Kulata Churna, Musta Churna, Lekhan Udvartan, Trifala and Trikoto mix with Vacha Churna and Lodra Churna is helpful. For Nasya, Anutel, Shadbandutel, Marichaditel are used in kapha dominant condition. For Vata, Shirabala tel Grut Nasya, and for Pitta condition, Prami Grut and Shatavari Grut used for the Nasya. In Patya and Apatya, dietary regulation is essential. Patya includes Yava, Kulatha, Takra, warm light food are green leafy vegetables, and Kulatha are beneficial. And for Apatya, curd at night time, excess sweets, bakery items, less sleep, heavy food, heavy fried food, and junk food are avoided. Proper dietary discipline significantly improves treatment outcomes. Lifestyle advice: regular exercise, that is Surya Namaskar, Sarvangasana, Matsyasana, Bhujangasana, should be beneficial in thyroid. Pranayam like Anulom Vilom, Ujjayi Pranayam, Snadi Shodhan, Brahmari is beneficial. Avoid stress, proper sleep cycle, no sedentary habits leads to the helps to maintain the Agni and hormonal imbalance. So this will correct the thyroid disorders. For the science support, we can go for the Ashwagandha, Amlaki, Guduchi, and Google preparations for long metabolic balances. Research scopes, clinical trials on Kanchanar, Google, Varunadikar, thyroid profile before and after treatment, Agni assessment skill development. These are the research scope for thyroid disorders in Ayurveda. Conclusion. In conclusion, thyroid disorders can be effectively understood through the Ayurvedic concept of Agnimandya and Galaganda. Ayurveda offers a root cause oriented holistic approach. Integrative management appears promising for improving metabolic health and quality of life. An integrative approach is most practical. Modern medicine provides hormone replacement and monitoring through TSH levels, while Ayurveda works at the level of Agni, Dosha, Dhatu. Combined management under supervision can be provide better long-term effect. Lifestyle correction includes. So these are my view on the thyroid disorders. Thank you.
Thank you, doctor. Thank you for the well-structured presentation. Next, we go to the hemorrhoids-related paper and poster presentation. First, we go to the paper presentation. I would like to invite Dr. Rushikesh Rameshwar Todkar for the paper presentation.
Thank you so much, sir, for help. Good evening, all. My name is Dr. Rushikesh Todkar. Next slide, please, sir. Today's my topic is modified procedure for hemorrhoids, that is the transannal sacrosuture mecopexy. We call it now Dr. Alok Gupta's procedure. I am PG scholar final year, Department of Shalatantra, SVNH Ayurvedic Mahavidyalaya, Rahuri Factory, Ahilanagar, Maharashtra. Next slide, sir. एकम शास्त्रम अधिहानो न विद्यात् शास्त्र निश्चयम तस्मात् बहुश्रुतं शास्त्रम विजान्यात् चिकित्सकः. We are doctors. We must know all, or we must read all the samhita, or we must know all chapters about it. Next, please, sir. तच्च शस्त्रकर्म अष्टविधम तद्यथा छद्य भेद्य लेख्य वेद्य एष्य आहारी विस्रव्य. The main concept behind this is Sivan karma. We on the basis of that I am going to present now. First of all, I tribute to late Dr. Shantakumar Shivta sir, which was the inventor of this procedure. Later, it was modified by Dr. Alok Gupta sir. Next slide, please, sir. My beloved Guru Dr. Alok Gupta sir, who modified this procedure. Next slide, sir. Hemorrhoids. There are main three problems. What are the hemorrhoids? Hemorrhoids are the prolapsing part during defecation. There are three major problems in hemorrhoids. Vascular problem. Bile mass increases due to blood stasis and trapping that causes mass increasing mass. Second problem is mechanical. Bile mass is pushed down and out due to laxity of ligaments, that is prolapse. And third problem is recurrence due to collateral formations. Next slide, sir. The inventor of this procedure is Dr. Shantikumar Chivte sir. What is the concept behind inventing this procedure was, there was very interesting story behind this invention of this Chivte's procedure. The surgeon operating on surgeon is that story actually. Dr. Shantikumar Chivte sir operated one surgeon to stop bleeding per rectum, and that's how this procedure was invented by Chivte sir. Next slide, sir. What are the advantages of transanal suture rectopexy? Number one, we earlier told there are some problems regarding mass, prolapse, recurrence. What are the advantages if we do transanal suture rectopexy? First of all, mass, the reduction of mass will be there. Ligation of each vein and artery, that is corpora cavernosa of recti. Total vascular ligation is done in this procedure. Second problem which will minimized by this procedure was prolapse, fixation of reduced mass to rectal muscles, and there are minimum chances of recurrence due to this, that is control of collateral formation, because in normal procedure there are chances of collateral formation and again recurrence of hemorrhoids. In this procedure we can able to stop, or we can able to hold the collateral formations, and pain factor is main in other surgeries, which are minimized by we are taking sutures 2 to 4 centimeter above the dentate line. The area above the dentate line is painless, we can say that. Below the dentate line it is painful, hence the pain is also not there in this procedure. The paper published by Dr. Shantikumar Chivte sir in this regard, as you see, transanal suture rectopexy for hemorrhoids, Dr. Chivte's painless cure for piles. Next slide, sir. How this procedure was beneficial? As we say, patients with mainly this procedure was done on grade 3 and grade 4 hemorrhoids, mainly where prolapse was seen. The patient with grade 3 and 4 hemorrhoids treated by double locking sutures, pexy, we can see the two lines are there in first picture. 98% of patients report pain levels 1 or 2, means there are minimum pain in this procedure, because we are taking sutures 2 to 4 centimeter above the deadline, and there are minimal chances of recurrence in this, 1.3% chances of recurrence in this procedure. Next slide, sir. What is the actual procedure of transanal suture rectopexy? Reduction of vascular mass is there. We are using the spinal anesthesia in this procedure. The most good position for operating this is mainly we are using the lithotomy position. We use jelly. Then we are first massage the pile mass and mucosa, and then we used our special design proctoscope, or that is the Chivte's proctoscope, which are specially designed again by my beloved guru Dr. Alok Gupta sir. Next slide, sir. These are the instrument as you seen in this picture. There is a Dr. Chivte's proctoscope, and the instrument regarding this are seen in there. The light source is seen. The special type of needle holders are there. You can see the 9 inches bigger size needle holder is there, and second is 6 to 5.5 inch needle holder is there. Next slide, sir. This is the light source. Actually, you are seeing. This light source is attached to the Dr. Chivte's proctoscope. Next slide, sir. This is the specially self-illuminating proctoscope, which the main design or main invention was Dr. Chivte sir, which is a special proctoscope which is made by him for this procedure. Next slide, sir. As you see, the main part of this proctoscope was the window and the margins. The main concept behind the hemorrhoids is now changing actually. Dr. Antonio Longo was saying that hemorrhoids are caused due to the partial prolapse. There is a protrusion of mass seen. Actually, in hemorrhoids, there is also partial prolapse is seen. Next slide, sir. What are the special points of this proctoscope? It is a special self-illuminating proctoscope, 4 centimeter in diameter, 14 centimeter in length, 1/8 portion of cylinder is cut and open window develop. It was useful in hemorrhoidal procedure, rectal bleeding, for biopsy taking or polyps, for polyp surgery, suturing internal opening of fistula also, mucosal prolapse of rectum. Next slide, sir. What is the anatomy behind this? As we said, the anatomy of anal cushion and trees muscle. Naturally, the submucosal anal cushions are anchored by trees muscle to internal sphincter. Here, all this is the normal natural anatomy of human being. What happen in hemorrhoids? These muscles are gone weak, and anal cushion is going to prolapse. Because of this procedure, the all lax part, which are part was supported by sutures. Here, all the lax supportive ligaments are strengthening due to the fixation. We are fixing there. We are fixing that lax part to its normal position. Next slide, sir. What is actual procedure? First, we give some position to patient, then we insert proctoscope under spinal anesthesia. The first line of suture was 2 centimeter above the dented line. We are doing a fixation of mucosa to internal sphincter muscle. The first stitch is 1 centimeter long, start at 3 o'clock. Why 3 o'clock position? Because there are less chances of bleeding while taking the sutures. We are taking double interlocking sutures to avoid the purse string effect in the patient. Mucosa of rectal muscle is partially tied. Second stitch start at the base of first stitch so that it overlap by few lock it twice. Double lock stitch continued all along the rectal circumference. Why? To avoid the purse string effect. Second line is 4 centimeter above the dented line. Next slide, sir. As you are seeing in this picture, we are taken 2 lines. The first line is 2 centimeter above the dented line, and second is 4 centimeter above the dented line. The distance between 2 line is 2 centimeter actually, and because of this high, the pain of patient, the pain factor was minimum. Next slide. As you see in this picture also, we are taken 2 suture lines. Next slide, sir. How deep we are going while taking the sutures? We cover submucosal part and double interlocking sutures are taken to avoid bursting effect. Next slide, sir. The main benefit of this taking 2 line of sutures is we can avoid or we can control the collateral formations, which are the main benefit of this procedure. The references you can get in early Merger's synopsis of surgical anatomy. Next slide, sir. Here I shown how we are taking sutures. There is a dented line. We take the first suture 2 centimeter above the dented line, and second was 4 centimeter above the dented line. Because of this, the prolapsing part is minimized, and pain factor is also minimum because of 2 lines are there. Hence, the collateral formations chances of collateral formations is less, and reoccurrence of hemorrhoids is are also going to minimize. Next slide, sir. What are the fundamental errors in other techniques? As you can see in Milligan Morgan, if we do on patient, then there are chances of recurrence 18 to 20%. Not good for circumferential piles. Very painful procedure. External piles do not require treatment. That is, we cannot do as we have to do procedure. Next slide, sir. Next slide, sir. DGHL, Doppler guided hemorrhoidal artery ligation. How procedure was beneficial over this? In DGHL, there is no control of secondary piles. The search of branches of plexus, no definite number of branches, no Doppler, only 4 to 5 branches are founded in Doppler. There are no actual fixation of vessels we are doing in this procedure. Actually, it is more beneficial than DGHL. Next slide, sir. As we seen, we are taking two suture lines which are beneficial to avoid collateral formations. As you've seen in this picture, the collateral formations are chances of collateral formations are very less in transannular suture rectopexy. Next slide, sir. Uh, Stapler mucopexy. How transannular suture rectopexy is beneficial over stapler mucopexy. In a stapler mucopexy, there is a recurrence rate is about 18 to 20%. Prolapse of coil mass is common after doing a stapler mucopexy also. No thing is fixed to internal sphincter. We are literally cutting in stapler mucopexy. No blood vessels are ligated in that procedure. Rectal volume reduce. Mm, mucosa has poor strength in this process. These are the fundamental errors in stapler mucopexy over the transannular rectopexy. Next slide, sir. Next slide, sir. Next slide, sir. In stapler method, we are cutting that part actually, uh, uh, which is and in new surgeons we can control the bleeding. In transcendental suture rectopexy, the bleeding is minimal. There is no bleeding in the transcendental suture rectopexy, or bleeding is having there but very minimal bleeding. Next slide, sir. How beneficial transcendental suicidopexy. Because of this, as we discussed, there is no collateral formations are there, recurrent chances are less, and prolapsing part was fixed to that portion. Next slide, sir. Recently, we got patent for this procedure under Dr. Alok Gupta, sir, which was now recommended by all over the world. We just got patent for this procedure last year, 2025. Next slide, sir. These are some pictures pre-op and post-op. Before procedure, you can appreciate the pile prolapsing part, prolapsing pile masses, and after the procedure. Next slide, sir. These are some pictures you can see uh, because of this how this procedure was beneficial over stapler, over Millikan Morgan procedure. Next slide, sir. Next slide, sir. You can see these pictures, all this. Thank you so much for giving me your valuable time. Thank you so much, sir.
Thank you, doctor. Thank you for the well-explained paper presentation. And one more poster presentation is there.
This is my post presentation modified procedure for hemorrhoids, that is transanal suture, sacrosuture mucopexy, Dr. Alok Gupta's procedure. As we've seen recently, there are lots of methods for treatment of hemorrhoids disease, but according to Dr. Antonio Longo, every patient of hemorrhoids is having internal prolapse of rectum, and he is doing MIPH, that is minimal invasive procedure for hemorrhoids, or STAR, that is a staple transanal resection of rectum. But we have think to do not excisional treatment for the same. Sir, please, can you rotate the slide, please? What is our aim behind this? Our main aim was to provide better non-excisional minimal invasive procedure for hemorrhoids. What we are using materials, this procedure was used for 140 cases. Recently, I said we got patent on this procedure. We actually done. We are maintained a record of 140, and now we are doing this procedure still now. 140 cases we are studied. according to symptomatic grade 2, 3, and 4. Mainly, this procedure was we are doing in grade 3 and grade 4 hemorrhoids. We maintain data for 69 males and 71 females. But what criteria are excluded? This procedure was excluded for thrombohemorrhoids, solitary rectal ulcer in IBD patients, in anatomical malignancies like a cancer and anal stenosis. These are excluded from our data. What are the methods we are used? Under all expected precaution, patient in semi position, painting and trapping done. Then Dr. Chuta's proctoscope is introduced in rectum, and the posterior rectal wall is fixed to place sacral fascia. That is sacrorectopexy, by taking 3 to 4 PDS sutures. PDS suture is 40 mm round body needle, and we're taking sutures at S3 level to sacrococcygeal junction, and single layer circumferential suture rectopexy is done then at 4 centimeter above the dented line by 20 vicryl 27 5 by 8 circle round body needle. Then we do mucopexy. We are combine 3 procedures here, that is sacrorectopexy, suture rectopexy, and mucopexy. Mucopexy is done 2 to 3 centimeter above the dented line at 3, 7, and 8 1 o'clock by 20 vicryl 30 round body needle. As you seen in below pictures, that we are first do sacrorectopexy, then we do suture rectopexy, Dr. Chuta's procedure, and then we do mucopexy. What are the results we got in this procedure? The hemorrhoidal masses are reduced 90% immediately post-operatively on the table, and further reduction within 7 to 14 days. Post-operative minimum pain is there. There is minimum pain in we are seeing in only 11 patients, which 140 cases. No recurrence of hemorrhoids, or no incidence of impairment of continence, which are main factor in this procedure. Continence was maintained there. What is the conclusion? This procedure is more simple and economic for correcting the all pathophysiology of hemorrhoids disease with minimal hospital stay and postoperative pain and bleeding. Because as we see in stapler method also, 24,000 rupees cost was there for one stapler. How this procedure is beneficial? It is the economic and more beneficial. Minimum hospital stay was required in this procedure, and postoperative pain, bleeding, and recurrence chances was very less. As you see in pictures, we are measuring that how area was fixed with help of scale. We are designing special scales for the scale also for that, for measuring that. We are under process for that. Thank you so much, sir, for giving me valuable time. Thank you so much, sir.
Thank you, Doctor. Thank you for the well explained and informative paper and poster presentation. Thank you so much, Doctor. And next we go to the another paper and poster presentation. First we go to the paper presentation. I would like to invite Dr. Pradisha for the paper presentation. I would like to invite Dr. Pradisha Limbhore for the paper presentation.
Okay.
Good evening, Doctor.
Good evening. I'll just share the screen.
Okay, Doctor.
Good evening, everybody. So my topic is synchronizing female physiology with seasonal rhythms. That is the role of Ritucharya, presented by Dr. Pratiksha Limbore, PTSR Department of Dr. D.Y. Patil Ayurveda Hospital and Research Center, Pimpri, Pune. So here is the introduction. So Ritucharya, the seasonal regimen outlined in Ayurveda, it mainly emphasizes adapting diet and lifestyle according to the seasonal variations to maintain the health and prevent disease. In women, reproductive physiology, including menstrual regulation, hormonal balance, fertility, and overall gynecological well being, is closely linked with the environmental and seasonal changes. The ancient Ayurvedic texts have elaborated on how seasonal transitions influences the three doshas. So, in women, reproductive physiology is especially sensitive to such environmental and seasonal fluctuations. The Ayurvedic texts highlight that factors such as climate, temperature, humidity, and daylight influence not only the external environment but also the internal biological rhythm, that is dinacharya and rutucharya. These rhythms in turn regulate menstrual cycles, hormonal secretions, ovulation, and overall gynecologic health. Okay, next slide. So here is in a Rutucharya seasonal regimen that includes diet and lifestyle. It is linked with your reproductive health in women. It mainly influences your menstrual cycle, hormones, fertility, gynecological well-being. Next slide. So the aim of the study is to explore the significance of Rutucharya in female reproductive health by reviving classical Ayurvedic references and correlating them with the contemporary gynecological conditions. So here are the objectives is to explore the significance of ahara, that is diet, of course, vihara, that is lifestyle, in preserving and promoting female reproductive health, to categorize and explain the common gynecological disorders which are based on Ayurvedic principles, to evaluate the role of Ayurvedic dietary guidelines in the management of Stree Rog, that is women's health disorder, and to revive and emphasizes the effectiveness of Ayurvedic therapeutic approaches in addressing various female reproductive health issues. So the study design is a conceptual review study actually. Source of data is of course from Archarak Samhita, Sushrut Samhita and Ashtang Hriday. Contemporary literature on PCOS, dysmenorrhea, infertility and menopause. Ayurvedic and integrative journals like PubMed, ResearchGate and case studies. So results is maintain Artav Shuddhi, that is purity of menstrual blood, then promotes Rutu Shuddhi, that is regular menstruation, enhances Garbhadharana Shakti, conception capacity, then Dosha, that is season correlation observed in gynecological disorders. So here is the main chart, that is seasonal influence of three doshas on female reproductive health. So in Varsha Rutu, the dominant dosh, as we know all, the Vata dosh, and possible gynecological problem is menstrual irregularity, dysmenorrhea, and amenorrhea. In Sharad, that is the dominant dosh is a Pitta, and we know excessive menstrual bleeding, inflammatory conditions, and emotional instability are the problems. Then in Grishma, Pitta, heat-related infection, menorrhagia, aggravated emotional symptoms are there. Then in Hemanta Rutu, dominant dosh is a kapha, so sluggish metabolism, ovulatory delays, weight gain, kapha-related gynecological issues. In Shishira, kapha, that is dominant dosh is a kapha. The main gynecological manifestations are digestive impairment, polycystic ovarian syndrome tendencies. In Vasanta, the dominant and the main possible gynecological manifestation is delayed ovulation, Shwetapradar, Mandagni, insulin resistance due to PCOS and emotional dullness. Okay, so role of ahara in Stree Rog, mainly for first we will see for Vata. It includes warm cooked food such as soups, whole grains and dietary products. Avoid dry, cold and processed food because they are already light. Consume ghee and sesame oil for lubrication and nourishment. Favor root vegetables, nuts and seeds which mainly contains oils. Drink herbal teas like ashwagandha and brahmi for hormonal balance. For Pitta, it favors cooling foods like cucumber, coconut, and leafy green vegetables. Limits spicy, fried, and fermented foods to prevent excessive heat in the body. Consume sweet, bitter, and astringent foods like pomegranate, aloe vera, and fennel. Drink cooling herbal infusions such as coriander water or rose water. Now for kapha, of course, avoid heavy, oily, and sweet foods that increases congestion and sluggish metabolism. Include light, warm foods like barley, lentils, and bitter vegetables. Use spices like ginger, turmeric, and black pepper to improve the digestion. And prefer steamed and grilled foods over the fried items. So, role of a vihara, the key points are Brahma Muhurta, that is eating early rising, Mala Visarjan, that is regular elimination, Abhyanga, daily massage, Vayama, that is exercise, Snehan, bath, Pranayam, that is meditation. Role, it regulates menstrual cycle and hormonal function. It helps to prevent gynecological disorder like Artavakshay, PCOS, and Yoni Vapat. It supports emotional stability and stress reduction. In menstrual disorders, it regularizes menstruation with Dashamula Arishta and Ashoka Arishta. It relieves cramps with warm sesame oil massage and turmeric meal. Use fennel and ginger tea to ease bloating and pain. For PCOS, incorporate kapha pacifying diet with low sugar intake. Use Ayurvedic herbs like Shatavari, Lodra, and Trikotu for metabolic balance, engage in regular exercise, and avoid sedentary habits. For infertility, strengthen reproductive tissue with Shatavari and Ashwagandha, maintain proper Agni with Trikatu and Triphala, follow a balanced diet rich in whole grains, ghee, and nuts. For menopause, manage the hot flushes with cooling herbs like Brahmi and Guduchi. Nourish the body with ghee, dates, and milk. Practice meditation and relaxation techniques for emotional balance. Now, the role of Panchakarma. So, the first is woman. Of course, it is useful in kapha dominant disorders like PCOS. Then, Virechana is for pitta related menstrual disorders and skin disorders. Basti is to regulate the Apanavat. Uttar Basti, it is specialized for uterine cleansing and infertility management. Nasya is useful in hormonal balance via hypothalamus pituitary axis, that is HPO axis. So conclusion is Rutucharya provides a seasonal framework to align diet, lifestyle and behavior with natural rhythms. It helps in maintain of three dosh balance, especially Vata crucial for reproductive functions. It supports regular menstruation, hormonal balance and healthy ovulation. It prevents seasonal aggravation of Stri Roga like PCOS, dysmenorrhea and infections. It acts as a preventive and promotive tool across all phases of woman's life, that is menarche to menopause. Integrating Rutucharya into routine life enhances the fertility, emotional well-being, and overall reproductive vitality. So here are the references, and yeah, that's it. Thank you so much.
Thank you, Doctor. Thank you for the paper presentation. And one more post presentation is there.
So the topic for my presentation is Uttarbas tubal blockage, a clinical presentation by Dr. Krishnkant. So Uttarbas tubal blockage is actually responsible for 25% male infertility cases. The obstruction may be the functional, that is spasm or the edema, because of the fibrosis or adage hydrosalpinx. So this mainly includes a PID, endosis or post. So from Ayurvedic perspective, this condition can be correlated with Vandyatva, that is we call it as infertility, and Artava Srotodushti, Apan Vatadushti and Kapha Avaran, that is causing mainly causing the Marga Aprut. So this obstruction or this Sangha in Artava Srotas, it prevents the proper movement of Bija and Artha. So classical foundation of Uttar Basti, the references are given in Charak Samvita, Siddhistan and Sushrut Samvita Chikitsastan. It is indicated in Vandyatva, in Yonivapat Chikitsa, in Artavdrushti Chikitsa. So Uttar Basti is considered superior among the Basti therapies for urogenital disorders because it delivers medicine directly into the site of pathology. Tubal block mainly involves the vata vitation, that is improper movement. Then kapha is responsible for the obstruction. Pitta, that is in the PID cases, mainly responsible for the inflammation. And dhatukshay, that is for the fibrosis. So Uttar Basti directly reaches the uterine cavity, spreads towards the fallopian tubes. It acts locally and systematically, and it also corrects the apanvata. Aim and objective. So, to evaluate the clinical efficacy of Uttarbasti diagnosed cases of tubal blockage. So, material and method study design, it is an open label clinical study which includes mainly women from 20 to 35 years, which is the main fertile period of female. HSG is performed to confirm the unilateral or bilateral block. Exclusive criteria is the active infection if she is known case of PID or severe endometriosis. The drug is given the Falagrita or Ksharatela depending upon the pathophysiology or pathology. The dose is 3 to 5 ml intrauterine. The time, appropriate time is post menstrual phase, ideal because cervix is slightly open, os is slightly open, and there are no chances of pregnancy. We can give it for the 3 cycles. And then assessment criteria, HSG before and after treatment can be given. The probable mode of action is mainly first for on Vata dosh, it is for Vata Shaman, which regulates Apanvat to improve the reproductive tract motility. Then on Srotodushti, remove the obstruction in Artavah Srotas. In Ushna and Tikshna properties, particularly in Kshar Tel, we can say, it breaks down reduce the fibrotic tissues. Sneha effect is mainly responsible to soften the fibrotic tissue and it reduces the dryness. Inflammatory action is gluta-based preparation, which reduces the chronic inflammation. Improved localization, intrauterine instillation may enhance the tubal perfusion or it improves the endometrial receptivity. So mechanical flushing effect can be there. Modern management option are tubal canalization or laparoscopic audiolysis or IVF. These are the limitations of modern treatment. Then Uttar Basti offers why Uttar Basti is more effective than that of the modern treatment, because it is minimal invasive option, it is cost effective, it is OPT based procedure. Actually, some of the consultant do it on OT basis, but mainly on OPD based procedure. Root cause oriented, mainly dosh and Srotas can be done. It is more effective functional block or margins or early fiber, less effective structural disease or severe hydrocephalus. It is actually contraindicated. So some limitations are there for this study. It is small sample size, no control group can be there, and discussion Avaran removal restores tubal patency, as I said. So conclusion, Uttar Basti is safe, economical and promising Ayurvedic intervention in selected cases of tubal blockage and may improve fertility outcome. It is safe, economical and promising intrauterine therapy in selected cases of tubal blockage. It works through Srotodushti, Vata Shaman and anti-fibrotic action, potentially restoring the tubal patency and improves fertility outcome. So it is actually a breach of classical Ayurvedic wisdom with modern infertility challenges. Future scope are larger randomized control trial can be taken, comparative studies with laparoscopy can be done, and integration in infertility management protocols can also be done. Thank you.
Thank you, Dr. Pradiksha. Thank you for the insightful paper and poster presentation.
Yeah.
If we go to the eclampsia related case study, I would like to invite Dr. Sonali Suryakant Kamble for the paper presentation. I would like to invite Dr. Sonali for the paper presentation.
Good evening, sir. My name is Dr. Sonali Kambe. I am from Sumati Bhasha Ayurvedic College. My topic name is case presentation on eclampsia. Eclampsia, 10% of pregnancies are complicated by hypertension. Eclampsia and preeclampsia account for about half of this case worldwide. Term eclampsia coined in 1619 by Verandus, defined as unexplained seizure conversion in a woman with preeclampsia. Science, we call it eclampsia, preeclampsia or eclampsia when a BP is more than 140/90, proteinuria or edema. Pathogenesis, abnormal placental artery formation. Placenta does not anchor deeply into the uterine wall. Imbalance of growth factors and antigenic factors. Genesis of impedance, arterial narrowing, increased BP, leaky vessels, edema, abnormal cerebral flow, blood flow, seizures. Etiology, endothelial cells dysfunction in blood vessels, abnormal protein production for placental vessel growth, abnormal capillary and muscle development in placenta, increased human sensitivity affecting the placenta blood flow, increased hormonal sensitivity regulating BP. Risk factor, family history of preeclampsia or eclampsia, poor previous pregnancies outcome like IUGR, abruption, placenta or fetal death, obesity, chronic hypertension, renal disease, vascular connective tissue disorder, gestational diabetes, multifetal gestation, or age more than 35 years, low socioeconomic status. Complications of eclampsia, antepartum hemorrhage, liver complication, encephalopathy, acute renal failure, jaundice, coma, fetal death, maternal death, premature delivery, placental separation, or brain damage due to seizures. Clinical manifestation, convergence, changes in reflexes, rapid weight gain due to the fluid retention, abdominal pain, severe headache, reduced or no urine output, blood in urine, dizziness, or excessive nausea and vomiting. Here are my case presentation. A 27 years old female primary by GA by 31.1 weeks, brought in conscious but disoriented state by relatives. History of conversion 15 to 20 minutes before when she came to our hospital. On examination, her BP was 160 by 100 mm of Hg, pulse 104. Per abdo uterus correspond to 30 to 32 peaks, contraction 1 contraction in 20 minutes, 25 minutes, FSH 136. There are some history, old tongue bite present, bipedal edema or mild vulval edema. Provisional diagnosis, antepartum eclampsia, severe preeclampsia with convulsions, 31 weeks of gestation. Immediate management, tablet laboratory 200 mg start given, Follis catheterization done, and magnesium sulfate loading dose was given, 4 gram in 100 ml of NS and 5 gram on each button. Obstetric management posted for emergency section under spinal anesthesia, indication eclampsia 31 weeks, deliver and shifted to ICU for further management. In ICU, magnesium sulfate maintenance dose given, tablet Nicardia 20 mg, BD stat given, BP monitoring done, urine output monitoring done, or cesarean monitoring done. Outcome, patient stabilized, no further convulsion, shifted to ward after 24 hours, general condition is good. Thank you.
Thank you, doctor. Thank you for the valuable paper presentation. Next, I would like to invite Dr. Anjali Naneshwar Ragibe for the poster presentation. I would like to invite Dr. Anjali for the poster presentation.
Yes, sure.
Good
I will
evening,
share
doctor.
my screen. Good evening, sir.
Okay, doctor, please share the screen.
Can you see,
No, doctor, not visible.
sir? Okay. Can you share the slide for me?
Okay, doctor, just a moment. And please start the session, doctor.
Okay. Good evening, everyone. Myself, Anjali Naneshwar Rakibe, Rasshastra final year student from SVNH Ayurved Mahavidyalaya, Maharashtra. My poster presentation topic is efficacy of Panchatikta Ghruta Gugur in acute fissure in ano, a review study. Introduction. Perikartika, a fissure in ano, is described as an ulcer in a longitudinal axis of a lower anal canal. Fissure in ano is common disease found in a person due to excessive straining during defecation, hard stool, or due to diarrhea. In Ayurvedic taste, Parikartika cause due to Vaman, Virechan Vapat, Bastikarma Vapat, and Upadrava of Atisar, Grahani, Arsha, Udavarta, etc. These symptoms are pain, bleeding from the anal region, swelling and a burning sensation. In this research work, Panchatikta Ghrudgugal is administered orally in the treatment of Parikartika. Total 40 patients are evaluated and assessment done on the subjective parameters like pain, bleeding from the anal region, swelling and burning sensation. In this research work, Panchatikta Gugur administered orally in the treatment of Parikartika. Total 40 patients are evaluated and assessment done on a subjective parameters like pain, bleeding from anal region, swelling and burning sensation. On basis of results, we concluded that oral use of Panchatikta Gugur are effective and economical treatment modalities in the management of Parikartika, that is fissure in ano. No complications were observed. Aims and objectives were to provide the better relief to the patient and evaluate the efficacy of oral use of Panchatikta Gugur in Parikartika patients. Materials. This procedure was used for 40 cases. According to symptomatic parameters, 15 males and 25 females were examined. Chronic fissure, the thrombosed hemorrhoid, fistula in ano, solitary rectal ulcer, IBD, anorectal malignancy, and stenosis were excluded. Methods: Panchatikta Ghrud Gugur is administered in 1 bati thrice a day with lukewarm water after the meal. It is a randomized controlled clinical trial. The result of therapy was assessed on the basis of the changes in a local as well as a general signs and symptoms. The results: the symptoms of the patients reduced 90% within 30 to 40 days with no other any complaint. In 10% patient, time taken for the relief of the symptoms was altered. Conclusion: Panchatikta Ghrut Gugur. The reference was taken from the Bhaisajya Ratnavali Kushtarog Adhyaya. That is, the Nimbasal, Guruji, Vasa, Patol, Kantakari. These are the Panchatiktak which are used with the Gugur, Ghrut, and 27 to 28 Prakshit Dravyas are mentioned in this pata. In this part, the Panchatikta Ghrut is used in the Nadivran and Bhagandar. So we have taken the reference from that Bhaisajya Ratnavali. As the action of the Panchatikta Ghruta are the anti-inflammatory, it has the healing wound properties along with relieving the pain and blood purification. So we can say that Panchatikta Ghrut Gugur are effective and play an important role in relieving the symptoms of pericarditis and help in the fast healing of the fissure in arrow. During this treatment, there was no need to put the patients under general anesthesia or hospitalization or need to take time off from the work. It was found that the treatment was not costly and has no adverse effect. Thank you.
Thank you, Dr. Anjali. Thank you for the well-structured poster presentation. Next, we go to the antepartum hemorrhage-related paper presentation. I would like to invite Dr. Ajit Kumar Ashok Kumare for the paper presentation on the topic antepartum hemorrhage. I would like to invite Dr. Ajit Kumar. Good evening, doctor.
Good evening. 2 minutes. Hello.
Your screen is visible, doctor.
Okay, sir. Thank you, sir. My name is Dr. Ajit Kumar Ashok Kumare. My topic name is antepartum hemorrhage. We'll be studying antepartum hemorrhage in 1, 2, 3, 4, 5 subtopics: definition, importance, causes, management of acute and prognosis. Bleeding in pregnancy. In early pregnancy, it's related with abortions. Second, after 28 weeks till the delivery, it is antepartum. It is called antepartum hemorrhage, which I am going to explain now. And the third one is postpartum hemorrhage, which happens after the delivery. The importance आहे खूप सारे obstetric emergencies आहेत. One of them is antepartum hemorrhage, PTH, convulsion, which means eclampsia. त्यापैकी एक असं आहे की antepartum. Attention should be sought immediately. If left untreated, can lead to death of the mother and fetus. It also can lead to DVT. Management reduces the risk of premature delivery, mortality, and causes. There are 5 causes for antepartum hemorrhage. First one is blood stain show. Blood stain will show, which happens in latent phase of labor. When the patient goes in labor, it will show, which is normal, which is not antepartum hemorrhage. It is differential diagnosis of antepartum hemorrhage. The most common cause of APH. Placental abruption. Most common pathological cause is placental abruption, which include placenta previa. Second most common pathological cause. Vasa previa, often difficult to diagnose, frequently lead to fetal demise because bleeding is totally fetal. Uterine rupture, which is less than 1% in scarred uterus. The causes: bleeding from lower genital tract, cervical bleeding as a cervicitis, cervical neoplasm, cervical polyp, cervical ectropion, yamular bleeding as a antepartum hemorrhage. Vaginal bleeding, trauma, neoplasia, vulval varices, infection, inherited bleeding problems, very rare, 1 in 10,000 women. Unexplained, no definite cause is diagnosed in about 40% of APS. Bleeding that may confuse with vaginal bleeding, GI bleeding, hemorrhoids, inflammatory bowel disease, urinary tract bleeding in UTI. तर antibiotic वरचे most common दोन causes की placenta previa आणि abruptio placenta. Okay, placenta previa definition. Insertion of placenta particularly or fully in lower segment of uterus. Placenta lower segment of uterus म्हणजे असल्यामुळं त्याच्या सेपरेशन मुळे जे ब्लिडिंग होते त्याला प्लासेंटा प्रिव्हिया. Etiology, no definitive cause. Endometrial factors, scarred endometrium, curettage for several times, abnormal uterus, anomalies of uterus maybe. Placental factors, large placenta, abnormal formation of placenta, developmental retardation of fertilizing. Risk factors for placenta previa, multiparity, advanced maternal age, prior LSCS or both uterine surgery, prior placenta previa, uterine structural anomalies, assisted conception, IVF. Classification of degrees of placenta previa. 4 grades. Grade 1, placenta encroaches lower segment but does not reaches the cervical os. Grade 2, reaches cervical os but does not cover it. Grade 3, covers the part of cervical os, partial placenta previa. It completely covers os even when the cervix is dilated. Fourth, placenta previa, clinical features. Recurrent painless vaginal bleeding. Abdominal findings, uterus is soft, relaxed, and non-tender. Contraction may be palpated. Presenting part is usually high, abnormal presentation. Maternal cardiovascular compromise. Fetal condition satisfactory until severe hemorrhage, maternal compromise. Vaginal examination should not be done. Investigations, diagnosis by ultrasound scan showing the placenta coming into lower segment. Transvaginal ultrasound is safe and is more accurate than transabdominal ultrasound in locating the placenta. Leading edge within the 2 centimeter of internal os, completely covering the is incompatible with normal vaginal delivery. Placenta previa complications, maternal, major hemorrhage, shock, and death. Renal tubular necrosis, acute renal failure, postpartum hemorrhage, morbid adherence of placenta, placenta accreta, complicates approximately 10% of placenta previa cases. Anemia in chronic hemorrhage, sensitization of mother for fetal blood in Rh negative patient, disseminated intravascular coagulopathy, DIC. Fetal complications, IUD, intrauterine death, hypoxic ischemic encephalopathy, cerebral palsy, placental abruption, premature labor. इमेजेस दिलेलं आहे की कन्सिल्ड हिमोरेज, आत हिमोरेज होते पण रिव्हील्ड होत नाही, तर त्याचं इमेज आहे रेट्रोप्लासेंटल ब्लड. अब्रप्शन प्लासेंटा, रेट्रोप्लासेंटल ब्लॉट्स प्लासेंटा सेपरेट होतो पार्शियली or completely. त्याची etiology, risk factors, increased age and parity, vascular disease, preeclampsia, maternal hypertension, renal disease, SLE, or APS. Mechanical factors, trauma, intercourse, sudden decompression of uterus in polyhydramnios, multiple pregnancies, smoking, cocaine, uterine myoma, premature rupture of supine hypotension. Risk factors for placenta previa, multiparity, advanced maternal age, prior LSCS or other uterine surgeries, prior placenta previa, uterine structural anomaly, assisted conception. Rupture of uterus, clinical features. Maternal, pain in between contractions, scar tenderness, vaginal bleeding, profound maternal tachycardia and hypotension, loss of uterine contractions, hematuria, postpartum hemorrhage may be a sign. Diagnosis and clinical features. Painful vaginal bleeding. Pain is usually continuous. Mild type abruptions less than 1/3. Vaginal bleeding may be present or absent. Abruption मध्ये severe type मध्ये abruption greater than 1/3 abruption व्हायचे. Large retroplacental hematoma असेल, vaginal bleeding associated with persistent abdominal pain, tenderness on uterus, woody hard uterus, change of fetal heart rate, CT. Features of hypovolemic shock. Complications of placental abruption, maternal DIC, hypovolemic shock, amniotic fluid embolism, renal tubular necrosis, acute renal failure, postpartum hemorrhage, sensitization of Rh negative mother for fetal blood, Sheehan syndrome, pituitary necrosis, maternal death. Investigations mainly to exclude placenta previa can detect retroplacental hematoma. Fetal viability. Most of the time, finding will be negative. Negative finding do not exclude placental abruption. CTG, sinusoidal pattern, fetal tachycardia, bradycardia, laboratory investigation investigations for consumptive coagulopathy, platelet count, BTCT, PTINR, APTT, liver and renal function test. वैसा प्रीविया एक cause है APH. The fetal blood vessels from placenta from umbilical cord crosses the internal os beneath the baby's head. The baby is presenting, but rupture of membranes leads to damage of the fetal vessels, leading to exsanguination of and death. High fetal mortality, 50 to 75%, because blood loss is totally fetal. Risk factor: eccentric or velamentous cord insertion, bilobed, second turret lobar placenta, multiple gestation placenta previa, in vitro fertilization, pregnancies, history of uterine surgery and DNC, eccentric velamentous insertions. So imagine second turret placenta, placenta, rupture of uterus, uterine scar adhesions, fetal membranes remain intact. Fetus is not extruded intraperitoneally. Separation limited to old scar. Peritoneum overlying is intact. Usually no fetal distress, maternal hemorrhage. Uterine rupture मध्ये काय होतं, separation of scar. Rupture of fetal membranes with extrusion results in fetal distress, maternal hemorrhage, maternal mortality. Fetal mortality is 35%. More in uterine rupture. Rupture of uterus, high index of clinical suspicion. In all cases of antepartum and intrapartum hemorrhage, uterine rupture must be excluded. Risk factors, rupture uterus, scar uterine, previous cesarean section scar, and other uterine surgery scars, grand multipara, shoulder dystocia, forceps deliveries, trauma, uterine abnormal. Complication: maternal hemorrhage, bladder rupture, maternal death, PPS, DIC, fetal complications, respiratory distress, hypoxia, cerebral palsy, acidemia, death. Comparison of abruption, previa आणि rupture. Abdominal pain present आहे abruption मध्ये, previa मध्ये absent आहे, rupture मध्ये variable असू शकते. Vaginal bleeding, abruption मध्ये old किंवा fresh दोन्ही असू शकते, previa मध्ये fresh, rupture मध्ये fresh. DIC is more common in abruption, rare in previa and rupture. Acute fetal distress is common in abruption, previa it is rare, rupture मध्ये common. Management of APH. Admit to hospital for assessment and management. Main resuscitation measures if shock or severe death. Airway, breathing, circulation. Senior staff must be involved. Consultant, obstetrician and consultant anesthetist, neonatologist. 2 wide bore cannulas to prevent shock. 2 IV fluids fast. Take blood for doping. Coagulopathy profile, liver and renal function. Examination: assess maternal and fetal well-being. Pallor, record temperature, pulse, BP. Perform abdominal examination. Note areas of tenderness and hypertonicity. Determine gestational age of fetus, presentation, position, auscultate fetal heart. No vaginal examination should be attempted at the speculum examination assess the cervix, bleeding, and exclude local lesion. History. Obtain a history of each patient's condition, including color and consistency of bleeding, quantity and rate of blood loss, precipitating factors, that is sexual intercourse, vaginal examination, degree of pain, site and type, placental location, review ultrasound report. Examination assess investigation arrange urgent ultrasound scan, fetal monitoring, continuous electronic fetal monitoring is indicated. RH negative woman should have Lehor-Betke test and be given prophylactic anti-D immunoglobulin. For preterm delivery, when immediate delivery is not necessary, maternal steroids to promote fetal lung maturity. Further management will depend on cause of APH, extent of bleeding, presence of fetal distress or not, gestational age of fetus, placenta previa management. Term delivery is considered. Grade 1 to 2 may be able to deliver vaginally. Grade 3 and 4 will require cesarean obstetrics. Early in pregnancy. Continuation of pregnancy is better if possible. Need bed rest. Educate patient regarding condition and risk. Fetal well-being and growth should be monitored. Medication may be given to prevent premature labor. Placental abruption management. Small abruption, conservative management depending on gestational health. Careful monitoring of fetal condition is needed. Rate or severe placental abruption, restore blood loss. Ideally, measure central venous pressure and adjust transfusion accordingly. Prevent coagulopathy. Monitor urine output delivery. Cesarean section or vagina. If coagulopathy present, if fetus is not compromised, or if fetus is dead, vaginal delivery. Rupture of uterus management, emergency laparotomy, deliver the baby, uterine repair if possible, especially in primary level, EPH hemostasis sequence, cesarean obstetrics may be preferred, multiple. Pressure previa management, urgent delivery. Most of the time, urgent LSCS, neonatologist involvement, aggressive resuscitation of baby with blood transfusion following delivery. Prognosis of APH, fetus may die from hypoxia during baby pregnancy. Perinatal mortality, more than 50%, even with tertiary care facilities. High rates of maternal mortality. Thank you.
Thank you, doctor.
Okay.
Thank you for the detailed presentation.
Thank you, sir.
And next we go to the another paper presentation on the topic postpartum hemorrhage. I would like to invite Dr. Shubham Damnath Karle for the paper presentation on the topic postpartum hemorrhage. Dr. Shubham, are you there? Dr. Shubham, are you there?
Hello.
Good evening, doctor.
Hello. Good evening, sir. Am I audible?
Yes, doctor, you're audible.
Okay.
Today's screen is visible, doctor.
Uh,
Please turn on your PPT.
PPT. 2 minutes. Yes,
Once again, share the screen, doctor.
yes.
Okay, now screen is visible. Please start the
Yes, sir.
session, doctor.
So my topic is postpartum hemorrhage (PPH), which is the most common cause of maternal mortality. I'm going to explain overview, causes, management, and prevention. Since definition of the postpartum hemorrhage is that postpartum hemorrhage is excessive bleeding after the childbirth, that is greater than 500 ml blood loss after vaginal delivery, or after cesarean section, it is 1000 ml, which is the most leading cause of maternal mortality worldwide. There are two types of PPH. One is primary, second is secondary. Primary PPH happen within 24 hours after delivery. We also call it as early PPH. And the second type is the secondary PPH, which we call as it as a late PPH after 24 hours to 6 weeks after postpartum. There are four causes mostly. We call it as the four T's. That is tone, trauma, and tissue, and thrombin. That is uterine attonity, most common. Then trauma, lacerations, and uterine rupture, tissue retain placenta or clots. Then thrombin, coagulation disorders like thalassemia, sickle cell anemia, or any others. There are risk factors for the PPH, that is prolonged labor due to the thin out of the lower segment, multiple pregnancy, polyhydramnios, previous PPH, induction or augmentation of labor, and anemia. The pathophysiology is that failure of uterine contraction leads to continued bleeding, open uterine blood vessel after placental separations, and hypovolemia and shock if untreated. The clinical features, that is excessive vaginal bleeding, tachycardia, hypotension, pallor and dizziness, and signs of shock. Management and initial steps, that is call for help, assess airway, breathing, and circulation, establish IV access, fluid resuscitation, monitor vital signs. Medical management, that is uterine massage, oxytocin first line treatment, methyl ergometrine, then prostaglandins, that is misoprostol and carboprost, and tranexamic acid. Surgical management, Ballard, balloon tamponade, uterine compression suture, that is B-Lynch, uterine artery ligation, and hysterectomy, life-saving measure. Then prevention, active management of third stage of labor, prophylactic oxytocin, early identification of risk factors, and skilled birth attendance. Complications, hypovolemic shock, disseminated intravascular coagulation, organ failure, or maternal death. Conclusion, PPH is preventable and treatable with timely intervention. Early recognition saves lives, and multiple disciplinary approach is essential. Yes, thank you, sir.
Thank you, Doctor. Thank you for the insightful presentation. And next, I'd like to invite Dr. Pradiksha Shakaji Paval for the paper presentation. Dr. Pradiksha, are you there?
Yes, sir.
Good evening, Doctor.
Good evening, all of you.
Your screen is visible, and please start the session, Doctor.
Okay. Good evening, all of you. Myself, Dr. Pratiksha Shahaji Pawar, second year PG scholar, Department of Shalakya Tantra. Today I am going to present an Ayurvedic approach to prevent commonly occurring Urdhva-Chaturgat Vikara, ENT disorders in Bala, and observational study under the guidance of Dr. K.S. Sangoli, sir. These are the contents of my PPT. So coming to introduction, ENT diseases such as acute otitis media, rhinitis, tonsillitis, and pharyngitis are common in the pediatric age group. Nutritional deficiency related ENT disorders are also frequently seen among children. India has a large pediatric population, accounting for about 35% of the total population. ENT disorders are more common in children than in adults. Causes include immature immunity, poor nutrition, unhealthy eating habits, and poor hygiene. Aim of study to observe commonly occurring ENT diseases and its immune measures accordingly. Observations, commonly occurring Urdhva-Chaturgat Vikara, that is ENT disorders in pediatric population commonly seen are as follows. So these are the diseases: acute suppurative otitis media. These are the symptoms, and commonly occurring age group is 3 to 15 years. Acute otitis externa, commonly occurring age group is 2 to 10 years. Otomycosis, 5 to 10 years. Wax, 2 to 15 years. rhinitis 5 to 15 years, allergic rhinitis same 5 to 15 years, infective rhinitis 6 to 12 years, sinusitis after the age of 5 years, stomatitis common in children, acute tonsillitis and laryngitis. The above observations were conducted in the ENT OPD over a period of 3 months. Common ENT diseases in children were mainly associated with low immunity. Malnutrition increases the risk of infections and mortality in children. Low socioeconomic status, poor diet, and poor hygiene negatively affect immune development. These factors increases susceptibility to infectious during infancy and later life. Adequate nutrition and Ayurvedic practices help in disease prevention and immune enhancement. So coming to preventive and immune measures for preventing ENT diseases. In Dinacharya includes daily regimens like Nasya, Kaval, Gandush, Abhyanga and Karnapuran for maintaining health. Nasya, that is Pratimarsha Nasya, involves instillation of oil into the nose, preventing dust entry and curing diseases of organs above the shoulder. It stimulates olfactory nerve endings and supports the central nervous system. Kaval and Gandush help prevent and cure oral and throat disorders by improving oral circulation. This procedure massage oral mucosa and strengthen cheek and facial muscles. Abhyanga should be done daily, especially on head and feet, to nourishes tissues and increases strength and agni. Shirobhyanga, Padabhyanga promote healthy hair, good sleep and vision. Karnapuran prevent ear disorders and balances Vata dosha. In a Rutucharya, involves following seasonal regimens to prevent seasonal diseases and maintain health. Ahara in Ayurveda helps maintain dosha balance and normal physiological function in children. Due to underdeveloped dhatu, children are more susceptible to infections. Light, balanced and nutritious diet is advised to boost immunity. Liquid diet should be given after 6 to 8 months, while heavy and constipating food should be avoided. Kapha aggravating foods like excessive sweets, fried items, and preservatives should be restricted. Vihara such as hygiene, yoga, Surya Namaskar, and pranayam improve strength and immunity. In a Rasayan therapy like Gogrutha, Godugdha, and Suvarna Prashan enhances Agni Oja and overall immunity. Suvarna Prashan, administration of processed gold in children, is a unique practice mentioned in Ayurveda as a Suvarna Prashan by Acharya Kashyap. The specific benefits of Suvarna Prashan are as follows: Medhagni Balavardhanam, Ayusham, Mangalam, Punyam, Vrusham, Varnyam, and Grahapam. So coming to discussion, this observational study shows that ENT diseases are mainly associated with low immunity. Poor diet, poor hygiene, and low socio-economic status are major contributing factors. Adequate nutrition during the perinatal period and early childhood is essential for immunity. Ayurveda emphasizes disciplined lifestyle through Dinacharya and Rutucharya. Daily practices like Nasya, Kaval, Gandush, Abhyanga, and Karnapuran strengthen Indriyas and Agni. Rutucharya advises season-specific diet and exercise for disease prevention. Rasayan therapy, including cow's milk, ghee, and Suvarna Prashan, improves immunity. Yoga, Vyayam, Pranayam, and Surya Namaskar help boost immunity and prevent infections. So coming to conclusion, according to Sushruta, the age from birth to 16 years is known as Balya. This age is highly susceptible to infections due to an underdeveloped immune system. Common ENT disorders in children include acute otitis media and allergic rhinitis, acute tonsillitis, pharyngitis, and infective rhinitis are also frequently observed. These disorders show a close association with low immunity. Ayurveda explains prevention, diagnosis, and management through Shalakya Tantra. The principle emphasizes prevention. Swasthasya swasthya rakshanam aturasya vikar prashamanam. Early immunity boosting measures helps prevent urdhva chatrugat vikaras in children. I acknowledge my guide Dr. K.S. Sangoli sir, my HOD Savita Angdi ma'am, principal Dr. Suhas Kumar Shetty sir, my parents, colleagues, and Swasthyabodha 2026 platform. These are my references. Thank you.
Thank you, Doctor. Thank you for the well-organized presentation. Next, I'd like to invite Dr. Devayani P. Dasar for the paper presentation.
Yes, sir.
I'd like...
Am
Good
I
evening,
audible,
Doctor.
sir?
Yes, Doctor, audible. Good evening, Doctor.
Good evening, sir. Am I audible?
Yes, Doctor, audible, Doctor.
May I share the screen, sir?
Okay, Doctor.
Is it visible, sir?
Yes, doctor. Screen is visible. Please start, doctor.
All right. Thank you so much. So myself, Dr. Devani Pidasar, professor from the Department of Shalya Tantra from the Mahatma Gandhi Ayurvedic College Hospital and Research Center, which is a constituent unit of the Tamil Institute of Higher Education and Research, deemed to be University, Pardha, Maharashtra. I'm going to present on the topic of a case control study for exploring the association of the Prakriti with the Bhagandar. So Ayurveda substantiates this psychosomatic constitution of an individual, which we are going to tell about the Prakriti. And basically, Deha Prakriti and the relation with the Bhagandar, that is a fistula in ano, is very like there's a physical, physiological, and psychological traits. So that lifestyle, that means a recommended diet and a lifestyle for the good health, preventative medicine, and the therapy, that all are going to connect it with this prakriti. So again, the phenotypic heterogeneity is the main complication encountered in the contemporary science, which relates with the Bhagandara. So Desh Prakriti Abhiyan, we know very well, and Vata Pitta Kapha, these are the Prakriti Parikshanas, doshas, and with the purpose of the study of association of this Deha Prakriti with the Bhagandar, that is Fistula and Ano, and evaluation of the same. So method inclusion criteria for these cases is that above 80 and under the age of 76 with the 70, and this Bhagandara patients who's having the symptoms of Bhagandara for less than or equal to the 5 years, that are considered under the age group this one. And from this study was carried out from the 2015 to 18, both incidences and prevalent cases attending my college, that is Mahatma Gandhi Ayurvedic College, with the written informed consent that were recruited in this research, and including criteria for the controls. As we know very well that Prakriti Parikshanas, that questionnaires given by the CSIR, CSR IGB, IGIB, New Delhi, from that who prepared and then given the written informed consent were recruited for the present work. Exclusion was done specially for the diabetes, hypothyroidism, and the other endocrinal disorders and the multisystemic disorders that are excluded, and the exclusion criteria for the controls that are the means less than 18 and more than 50 years of age, and those who are not willing for the participation of the study. Ethical clearance date is mentioned here only. So they have Prakriti, that pro forma was assessed by the CCRS, that scale, and CCRS Prakriti assessment manual also, SOPs, according to the SOPs given by them, that are used in this one. So Ekadoshish Prakriti I found is the 66%, while Dandvaj is the 25 to 30%. And the Samadoshas are 30 to 34%. After founding this data, all this data was analyzed with the chi-square test and man witness test with the SPSS USA version software 20.0, and the p-value is less than 0.05. That was the statistically significant. Here is the statistical values, having founding the results of this, having the age group of 18 to 30 and 31 to 40, 41 to 50, like that, with the p-values just depicting over here. Male and female, here we are getting the in female patients are more. In habitat, rural areas having the more, and with occupation wise, that the government employees, housewives, that also I got the more. They have Prakriti, so Vata Prakriti, Vata Pitta, and this that means Ekadoshish, Dvidoshish, and Samadoshish. So here are the cases that I found in the that experimental group and the control group, having the p-values depicted on the slide. So comparison between the dosha and Deha Prakriti among the cases and controls. Here I got in case experimental study that Vata, Pitta, and Kapha. So Pitta having the highest mean values with the standard deviations, that are the values at 53.79, and afterwards the Kapha, and finally Vata. And the Prakriti, Deha Prakriti, that means comparison with the Prakriti and the Bhagandara. So here again I got the Pitta values more than the Vata. Also the odds ratio I found for the Pitta Prakriti only. So present investigation has indicated that Deha Prakriti is a risk factor connected with the Bhagandara. Also, it is a diagnostic and preventative tool by adopting acceptable dietary patterns, and the patient education, that is the cognitive therapy, is effective in lowering improper conduct and fostering positive health behavior adjustment as according to their Deha Prakriti. So, Pradnya Parada, refraining from this Pradnya Parada can be done through this cognitive therapy, and definitely it may be evaluated in terms of evidence-based epidemiological research. So final conclusion is according to the chi-square test and the odds ratio, it is revealed that there is an association between the pitta dominance and development of Bhagandara. Afterwards, the pitta kapha deha prakriti has the highest incidence of Bhagandara, followed by the single vataj and kapha vataj. And finally, pitta is predominant, is a positive factor for the Bhagandara. So acknowledgement to that is I'm very grateful to my college and also the one of the university, Edoxia Research University, who has given the support for this the study, and my college, and there is no conflict of interest. Also, I am very thankful to Ayurapta organization for giving the chance to me to present over here. Thank you so much.
Thank you, Doctor. Thank you for the highly informative and intellectual enriching presentation. Thank you so much, Doctor.
Thank you so much, sir, for giving the opportunity. Thank you.
Thank you. Thank you, Doctor. And next we go to the another paper presentation. I would like to invite Dr. Rushikesh Kedarnath Kukade for the paper presentation. I'd like to invite Dr. Rushikesh Kedarnath for the paper presentation. Dr. Rushikesh, are you there? Dr. Rushikesh, are you there? Okay, next I would like to invite Dr. Sachin Shivaji Gawande for the paper presentation on the topic Pathyaviti in ulcerative colitis. I would like to invite Dr. Sachin for the paper presentation.
Myself, Dr. Sachin Shivaji Gawande, PG Scholar, Kai Chikitsa Department from Shiva Trust, Yeshwantrao Chavan Ayurvedic Medical College and Hospital, Chhatrapati Sambhajinagar. My topic is Pathya Apathya in ulcerative colitis and Ayurvedic perspective. I will be discussing dietary and lifestyle guidelines based on classical principles. I would like to thank Dr. Sandeep Kamble sir for special guidance. He is HOD and professor at our Kai Chikitsa Department. Ayurvedic understanding of ulcerative colitis. Ulcerative colitis can be correlated with Pitta Jigrahani, Pitta Jatisar or Rakta Tisar. Here Pitta Pradhan Tridosh involvement is seen. Rasa and Rakta are the dosha. Mandagni is seen as a cause. In Samprapti, vitation of the Agni leads to ama formation, which combined with aggravated Pitta causes inflammation and ulceration of colon mucosa, which leads to impaired absorption and assimilation, resulting in bleeding per rectum, that is Rakta Tisra. In Charak Samhita, in Chikitsa Sthan, Grahani Chikitsa Adhyay and Atisar Chikitsa Adhyay, pathophysiology and management and Rakta Tisar is mentioned. Here the main treatment focuses on Langan, Deepan, Pachan, Stamban and Pichabasti for ulcer healing. In Sushruta Samhita, Uttar Tantra, Atisar Pratishat Adhyay, Sushruta has mentioned diarrhea management. He has given special emphasis on Grahi, that is astringent drugs and formulations, surgical perspective, that is description of intestinal pathology, also diet recommendations, that is Laghu, Grahi Ahar for bleeding disorders is mentioned. In Ashtang Hriday Chikitsa Sthan, in Grahani Chikitsa Adhyay, dietary protocols are given. Special emphasis on Agni Deepan as a primary treatment is mentioned. Pathya recommendations, that is specific diet for Pitta type diarrhea, and herbal formulations like Kuttajarishta, Bilva preparations are also given. Now what should be the Pathya that is beneficial that should be taken during the disease course? Here are some cereals and pulses like white rice, that is shali, whole wheat, vermicelli, semolina, suji, green gram, moong dal, yellow lentils, well cooked and smashed. In vegetables, bottle gourd, that is lauki, ridge gourd, ash gourd, pumpkin, round gourd, sponge gourd, carrot, radish, turnip and potato. All these vegetables should be well cooked and non-spicy. In fruits, we should take pitta shamak fruits, that is such like bilwa, which is best for ulcerative colitis management. Pomegranate, that is dadima, it has cooling and astringent properties. Banana, which is ripe and well smashed. Apple, pear without skin can be used. In dairy products and fats, uh, we should take fresh curd, that is takra and buttermilk. Cow ghee, which is Varna Rupaka. Limited milk intake should be taken. In oils, cow's ghee, rice bran oil, olive oil can be taken in limited quantity. In spices and beverages, Shatapushpa, Dhanya and Jeera can be taken. In beverages, pomegranate juice, fresh coconut water, herbal teas which has cooling properties can be taken. In meat and soup, mouse rus, we can take chicken soup which is light and digestible among jungle mouse. Goat meat soup which is well cooked and having thin consistency can be taken. It is to be prepared as a yush, that is thin soup. Avoid heavy gravies. It has properties of brihan, that is nourishing, yet it is laghu in quality. What are contraindications in ulcerative colitis? Cereals, that is refined flour, that is maida, heavy grains, new rice, pulses like black gram, that is urad dal, kidney beans, chickpeas, vegetables like onion, garlic, ginger, tomato, spinach, and fruits, that is all citrus fruits of amla rasa should be avoided. Spices such as red chili, black pepper, excessive turmeric, sour curd, heavy cream, full fat products, beverages like coffee, tea, alcohol, carbonated drinks, and other deep fried spicy fermented foods should be avoided. One should follow ahar vidhi, like eat warm, freshly cooked food, ushna ahar. Small frequent meals should be taken. Avoid viruddha ahar, that is incompatible foods. Maintain regular meal timings, that is kal bhojan. In vihar pathya, regular sleep pattern, stress management, gentle walking after meal, avoid excessive physical exertion. Daytime sleeping should be avoided. Late night eating and irregular meals, excessive mental stress and anxiety, suppression of natural urges, all should be avoided. Some key herbs like kutaj, bilva, musta and lodra can be used in ulcerative colitis, which has following properties. Also yashtimadu, dadima, shalmali, arjuna are used. Treatment approach according to Ayurveda should focus on Dipan Pachan to restore digestive fire, Stamban to control diarrhea and bleeding, Vranaropan to heal intestinal ulcer, Pitta Shaman to pacify aggravated Pitta. Panchakarma in ulcerative colitis, Pichabasti, that is medicated enema, direct action on colon mucosa, anti-inflammatory and ulcer healing properties. It should be given with Yashti Madhu, Shalmali and medicated Grita. These are some classic formulations used in ulcerative colitis like Kutajarishta, Bilwadi Churna, Gangadhar Churna, Vataskadi Churna. All the references are taken from these classical texts like Charak Samhita, Sushruta Samhita and Ashtanga Hriday. Some references are taken from research papers mentioned following. So ulcerative colitis correlates with Pittash Grahani and Ayurveda, focuses on Pitta, pacifying cooling diet, avoid spicy, acidic, fermented foods, combined diet with lifestyle modifications. Thank you.
Thank you, Doctor. Thank you for the valuable presentation. And next, I'd like to invite Dr. Snehal Anil Jaibai for the paper presentation. I would like to invite Dr. Snehal Anil for the paper presentation.
Hello everyone, myself Snehal Dnyanoba. I'm doing PG in Compartment from Srimati Vaishwa Ayurvedic Mahavidyalaya. Here I'm presenting paper presentation on the topic of Ayurvedic management in Asthimajjagat Vata in pediatric patient with respect to cerebral palsy. It is a case study basically. Introduction. Cerebral palsy is a non-progressive neurological disorder caused by a brain damage before, during, or shortly after birth, impacting movements, muscle tone, and coordination. Cerebral palsy is a group of conditions that affects movement and posture. It's caused by damage that occurs to the developing brain most often before birth. Common symptoms include stiff muscle, that is spasticity, weak muscle, poor coordination, then tremors and delayed milestones, which is like walking and crawling. Cerebral palsy categorized by the type of a motor disorder and categorized by the body or body parts affected. So first is a motor disorder, which is first is a spastic, which is stiffness. 80 of the cases are of spastic cerebral palsy. The second one is a dyskinetic, uncontrolled movements, ataxic, poor balance or coordination, hypotonic, low muscle tone, and categorized by the body parts affected. First is a hemiplegia, second is diplegia, and third is a quadriplegia. Then causes, prematurity and low birth weight. Major risk factors, though many children with a CP are born at term. Then birth asphyxia, hypoxic ischemic encephalopathy due to a delayed cry, low Apgar score, or a prolonged or a obstetrical labor. Then third one is a brain damage or injury, which is caused by the lack of oxygen due to asphyxia, infection, stroke, or head injury, often during childbirth or early infancy. Then maternal factors like infections during pregnancy can increase risk. Then placental insufficiency, placental abruption, or a condition like a severe anemia, uncontrolled diabetes, hypertension. Then cerebral palsy is correlated. It's Ayurvedic correlation. In Ayurveda, Asti Majjagat Vata is a condition where aggravated Vata dosha localizes in Asti, that is bone, and Majja Dhatu, that is bone marrow or a nervous tissue. When correlated with a modern medicine, it shows a close resemblance to cerebral palsy, especially the spastic and the mixed type. Majja Dhatu in Ayurveda includes nervous tissue. CP involves central nervous system damage, which is correlated to the Majja Dushti. Then Vata governs all the movements, that is Chesta. And when Vata localizes in Asti Majja, motor dysfunction and stiffness happens. So hence CP resembles Asti Majja to Vata Vadi. Based on the Ayurvedic principles, the treatment protocol incorporating Deepan, Pachans, and along with Snehal's Veda was the Nasya Medya. So, case presentation. He had there was a patient, 3 years, female, child in a Saniguruji hospital, came with a complex of a partial leg folding, unable to sit without support, scissoring gait, unable to talk, drooling saliva, and a leg tie squint. After history taken, as per the narrated by the mother, baby was born preterm LBW and was admitted in an ICU for 1 month. USG showed third degree periventricular leukomalacia, for which MRI was done at the age of 4 months. During the procedure, baby had one episode of conversion, after which baby developed delayed development. Then after birth history taken, it was she was a moderate preterm, 32 weeks, 1.5 kg weight. Tried immediately after birth, and analysis were done for a placenta previa and a PPR. She was stayed for 1 month in ICU. Father was expired 3 years ago, and was known case of a TM. Her immunization schedule was not taken properly. Then general examination, she showed a pallor. There was a no icterial cyanosis, edema, or lymphadenopathy. Height 79 centimeter, weight 6.4 kg, head circumference 37 centimeters, chest circumference 42, and mid-arm circumference 30. On examination, she showed microcephaly, sparse dry hair, mongoloid slanting, retrognathia, depressed nasal bridge, koinonokia, pallor, frontal glossing, exaggerated deep tendon reflex, protruded tongue, long philtrum, persistent morose reflex, flat sole, scissoring gait, and the left eye squint. On developmental milestone, only head control was partially achieved and sitting with support achieved. Others was not were achieved, not achieved. Uh, then in the fine motor milestones, she was able to turn pages partially, but not was not able to reach for objects or transfer to hand. Then in language milestone, she was able to respond to name, understand simple commands, monosyllable or bisyllabus was achieved. And in cognitive or emotional, she shows a smile, social smile, eye contact, recognizes familiar people. Separation response was there and shows emotional emotions appropriately. Then upgrading for muscle power was done, and all the four links shows a 3 out of 5 grading for muscle power. And grading of a deep tendon reflex, bicep, tricep, and ankle reflex was not there. Supinator reflex was totally absent, and knee reflex was 3 out of 5. Then वात निदान वात प्रकोपक factors during pregnancy, गर्भावस्था, दोष दृष्टी, birth trauma, prematurity and धातुक्षय, संप्राप्ति, निदान वात प्रकोप, then मज्जा धातुक्षय, then चेष्टा हानि, स्तंभ and विकृत गति. लक्षण शोध अस्थिशूल, संधिशूल, भेदक, कालक्षय, चेष्टा हानि, सुप्ति and spasticity. Then brain injury relates to major drushti, spasticity, vata prakopa, hypertonia, uksha, kharaguna, vata, delayed milestone, vata affecting motor functions and weakness, dhatukshaya. Then chikitsa includes dipan pachan, sarvanga, snehan, sarvanga swedan, nasya, basti and medgadravya. Dipan pachan was done by the Shinti Siddha Jala, Dhanyak Siddha Jala, sarvanga snehan by the Hamantar Tela, Chandan Malakshari Tela, सर्वांग स्वेदन नाड़ी स्वेद पिंड स्वेद स्नेहन नस्य बाय पंचेंद्रिय धातुवर्धन तैल बस्ती बाय क्षीरबल तैल आणि दशमूलक वात and मेद्य द्रव्य used are संवर्धन घृत काल्यानक घृत फल घृत मेद्य रसायन.
Thank you, doctor. Thank you for the well explained presentation. Next, we go to the another poster presentation. I'd like to invite Dr. Rushikesh for the poster presentation. I'd like to invite Dr. Rushikesh for the poster presentation.
Good evening everyone. Myself Dr. Ruhat B. Mirkar, PG second year. First we see the introduction. In Ayurveda, Tamakshwas is a chronic respiratory disorder primarily affecting the Pranavaha Srotasas, respiratory channels, closely correlating with modern bronchial asthma. It is characterized by a vitiation of vata and kapha doshas, where excess kapha obstructs the natural movement of vata, leading to the symptoms like paroxysmal coughing and wheezing, means gurguraka, and severe breathlessness. So as Charak Acharya mentioned in Charak Chikitsa Sthan 17th Adhyay Shwasa, the hetu of Tamak Shwas include both Aharaj, Viharaj and Mansik hetu. First, we see the Apathya for Tamak Shwas. In Apathya, Ahar like Atyambupan means excessive intake of liquid, then dry food, Nishpava, Masha, Pinyak, Tila Taila, Pishtha, Vishthambi Anna, etc. So, these ahar are responsible for the vitiation of kapha dosha, and in vihar like lack of exercise, excess walking, vishamashana, exposure to dust and cold, and consumption of cold drinks, etc. These vihar are responsible for vitiation of vata dosh, as we are see that vata and kapha both are responsible for the pathogenesis of tamakshwas. So these ahar and vihar are included in apathya. Now we see the pathya. So in pathya, first is grains like old rice means puran shali, wheat, godhum, and barley means yava, which provides light, warm nourishment that cleanses the respiratory channels by scraping away the excess mucus means kapha and restoring smooth airflow in the respiratory tract. Next are pulses. In pulses, green grams and horse gram are highly beneficial for their kapha reducing property. Next are vegetables like garlic, pointed gourd, and drumstick means shigru and ginger are which reduces the bronchial inflammation, clear the airway obstruction, and liquefy the sticky mucus for easier expulsion in the respiratory tract. Next are fruits. Fruits includes dates, grapes, and citrus fruits like lemon in moderation, providing antioxidant support to strengthen the respiratory lining and reduces the airway sensitivity. So these fruits are very beneficial for tamakshwas vyadhi. Next is conclusion. So together we are conclude that ahar act as both prevention and cure in tamakshwas, targeting the underlying pathophysiology through dosha pacification, agni deepan, as well as srodoshodhan. So these apathya and pathya are very important to understand in the tamakshwas patient. Thank you.
Thank you, doctor. Thank you for the valuable poster presentation. And next we go to the another presentation. I would like to invite Dr. Ashwini Shivajirao Ledkar for the paper presentation. I would like to invite Dr. Ashwini Shivajirao for the paper presentation.
Hello, myself Ashwini Shivajirao Lindikar, PG second year student, Ayurveda Sanhita and Siddhanta department. My paper presentation topic name is Trivid Bodh Sangraha, Analytical and Epistemological Review. Ayurveda Introduction. Ayurveda is a shastra based on structural knowledge. Every shastra requires Vishaya, Prayojan, Adhikari and Sambandha. Understanding of shastra depends on proper comprehension tools. Ancient acharyas provided interpretative methodologies. One such important concept is Trivid Bodh Sangraha, Hetu Linga Aushad. Classical reference concept rooted in Charak Samhita Sutrasthana, Sushruta Samhita Shastra Lakshan discussion in Tantra Yukti. Commentators like the Chakrapani Datta elaborate the interpretative framework from Charak Samhita Sutrasthan 1. Hetulinga Aushadhanyanam Swasthasya Atur Parayanam Trishutram Shashvatam Proktam Brahmanam Paramarshina. Knowledge of Hetu, Linga and Aushad is the eternal Trisutra expounded by Lord Brahma. This is the foundational reference of Trivid Bodh Sangraha. Nirukti. Trivid means threefold, Bodha, that which is to be understood. Sangraha, compilation or collection. Thus, Trivid Bodha Sangraha means three categories of knowledge that are to be understood in a Shastra and also necessary for understanding disease and health. Hetu, Charak Samhita Sutrasthan 1 describes causes as Ati Yoga, Ayoga, Mithya Yogascha Trividha. Improper utilization of time, intellect and senses are causes of disease. Also, Prajnaparat Hetu represents etiological understanding, preventive medicine basis, foundation of Nidan Pancha. Linga means Lakshana. From Charak Samhita Lingam Nama Vyadhi Lakshanam. Linga includes Purva Roop, Roop, Upashay, Anupashay, Pratyaksha, Anuman. Okay. From Aushad, from Charak Samhita Tadartakari Aushadam, that which counteracts Hetu and Linga includes Shodhan, Shavan, Nidan, Parivarjan. Clinical insights. Aushad is not only drug, it includes Ahar, Vihar and Acharya. Sushruta Samhita Sutrasthan. Disease understanding is structured as Nidan Lakshan Chikitsa. This directly reflects Trivid Bodh Sangraha. Commentary.
Insight. According to commentator Chakrapani Datta, Trisutra, Hetulinga Aushad is the essence of entire Shastra. Without understanding these three, Shastrartham Grahanam na sambhavati. Applied example. For example, Jvara from Charak Samhita, Jvara Chikitsa. Hetu is Dosha Prakopa. Linga, Ushnata, Trushna, Angamarda इत्यादि लक्षणे. औषध लंघनं प्रथमं कार्यं लंघनं स्वेदनं काले. This demonstrates practical Trivid Bodha Sangraha application. Philosophical depth. Trivid Bodha aligns with Ayurveda Darshan concept Hetu Karana, Linga Karya, Aushad Pratyanik. Thus it reflects universal causation principle. Relation with Pramana, component Praman. Okay, Hetu Anumana Praman, Linga Pratyaksha Praman, Aushad Yukti Praman. Hence, Trivid Bodhi is epistemologically complete. Analytical interpretation. Trivid Bodha is diagnostic model, therapeutic model, research methodology, educational framework. Entire Samhita structures follows this triad. Research perspective. Modern research model, cause pathology intervention. Ayurveda model, Hetu Linga Aushad. Ayurveda anticipated structured medical reasoning. Critical analysis strength काय scientifically structured, logically sequenced, clinically applicable. Limitations. Requires knowledge of tantra yukti, shastrartha, commentary, tradition. Conclusion. Trivid Bodha Sangraha is the cognitive and clinical backbone of Ayurveda. It integrates etiology, diagnosis, therapeutics. Understanding Trisutra equals understanding Ayurveda itself. Thank you.
Thank you, doctor. Thank you for the wonderful presentation. And next, I'd like to invite Dr. Manisha Dnyanoba for the paper presentation. I would like to invite Dr. Manisha for the paper presentation.
Namaste, myself Vaidya Manisha Dnyanoba. Today, my paper presentation topic is an integrated approach for diagnosis and management of Sarvangavata with special reference to Guillain-Barré syndrome. Introduction. Vayu is responsible for the movement or motor function of the body, and when the motor functioning of all the limbs are compromised, it is termed as Sarvangavata. The advancement in the research field of Ayurveda led to understanding the concept of newly evolving diseases which are not mentioned in the classics of Ayurveda, such as Guillain-Barré syndrome. Guillain-Barré syndrome is an acute inflammatory demyelinating polyneuropathy system that attacks the peripheral nervous system, that is peripheral neuropathy that affect the peripheral nerves. Guillain-Barré syndrome manifests as rapidly evolving areflexic motor paralysis, which is usually an ascending paralysis where weakness starts from the lower limbs and then ascends to the trunk and upper extremities. This study contributes to bridging the gap between traditional Ayurveda and modern diagnosis and management of Sarvangavata. Material and method. Data related to Vatvyadhi is compiled from the various texts of Ayurveda, also some contemporary books and research articles on the Guillain-Barré syndrome has been studied. Review of literature. Pittam pangu kafam pangu pangovo maladhatava vayunahi yatra niyante tatra gachanti meghavat. According to above shlok, in most of the diseases, Vata plays an important role assessing in motor function of the body. The pathophysiology of Vata Vyadhi is of two types, that is Dhatuk Shayjanya, that is nutritional, Margavrodhajanya, that is obstructive. Morbid increased Vata is associated with the decreased tissue element along with the other Pitta and Kapha dosha. Vital Vayu causes depletion, that is Kshaya, of Sira Snayu Kandara. It results in losing the functions either one part of the body, that is Ekanga Roga, or whole part of the body, that is Sarvanga Roga. GP syndrome is acute paralytic neuropathy affecting peripheral nervous system. The pathophysiology occurs due to molecular mimicry. Antibody produced against the infectious agents matches the proteins on the nerve cell. Thus, the antibody may target protein on myelin sheath of motor nerve or nerve axon and damage the nerve cell, leading to the neuropathy. Discussion. Sarvanga causes. It is due to dietary factors, unhealthy habits, agontuch causes, infection causing agents, trauma, etc. Pathophysiology of Sarvangavata. In Sarvangavata, vital vayu causes depletion, that is kshaya, of Sirasnaya and Kandara. It will result in losing or disturbing the functions of the whole body. Diagnostic criteria for Sarvangavata, Roga and Rogi Pariksha. Discussion. Guillain-Barré syndrome causes infections causes by Campylobacter jejuni, cytomegalovirus, Epstein-Barr virus. Campylobacter jejuni causes gastroenteritis. Pathophysiology of Guillain-Barré syndrome. While in GBS, the antibody may target the protein on the myelin sheath of motor nerve or nerve axon and damage the nerve cell, leading to the neuropathy and weakness in the limbs. Diagnostic criteria for the Guillain-Barré syndrome: progressive symmetrical weakness of greater than one limb, hyperplexia or areflexia, lab investigations, that is CSF examinations by lumbar puncture test to study the race proteins, radiological investigation, that is MRI, Sarvangavata management, Snehan with the help of Chandanvala Lakshadi Tel or Dhanvantar Tel, Svedan by Shashtikshali Pindasved, Vasti, Panchatikta Kshiravasti, Nasya by Anutel, Shaman Chikitsa, Ekangavir Ras, Ashwagandha, Amalki, Guduchi, etc. Guillain-Barré syndrome management, IV immunoglobulins, plasma exchange to remove the antibodies, venous thrombus embolism prophylaxis, low molecular weight heparin that cause the heart issues, avoid steroids, respiratory failures. Conclusion. The remarkable resemblances between the causative factors, pathophysiological processes, and primary symptoms of the Sarvangavata and Guillain-Barré syndromes underscores the potential advantages of an integrated approach. This approach has the promise of enabling early diagnosis and optimizing treatment strategies for these conditions. This integrated approach not only enhances patient outcomes but also equips healthcare providers with the valuable tools to affirm their clinical assessments and provide the more effective medical care. Thank you.
Thank you, Doctor. Thank you for the insightful presentation. And next, I'd like to invite Dr. Agna for the paper presentation. I would like to invite Dr. Agna for the paper presentation.
Good evening, respected panelists. Myself, Dr. Ahna Anil, PG scholar from Prasuti Tantra and Preroga Department, CSMSS Ayurved Mahavidyalaya, Rupnalaya. Today, I am presenting on importance of Uttarabasti in female infertility. Infertility is defined as failure to conceive after 1 year of regular unprotected intercourse. According to WHO, approximately 1 in 6 couples are affected globally. It leads to significant psychological stress, social stigma, and financial burden, especially due to ART procedures. The major causes of female infertility include PCOS leading to anovulation, tubal blockage, endometrial defects, and cervical factors. These factors interfere with ovulation, fertilization, and implantation. Ayurvedic concept of conception. In Ayurveda, infertility is termed as manjutva. Conception depends on 4 essential factors: Rudu, Kshetra, Ambu, and Bija. Any defect in these leads to infertility, and Vadadosha plays a key role in its pathogenesis. Types of infertility. Acharya Charaka has described 3 types: Vandhya, absolute infertility; Apraja, It may be correlated as treatable infertility and suppressor. May be correlated as secondary infertility. This classification helps in understanding prognosis. Uttarabasti. Uttarabasti is a specialized panchakarma procedure where medicated oil or decoction is administered through the genitourinary route. It provides direct intrauterine drug delivery, making it highly effective in gynecological disorders. Indications. Uttarabasti is indicated in infertility, tubal blockage, anovulation, endometrial disorders, menstrual disorders. Thus, it addresses multiple causes of infertility. Timing of Uttarabasti, it is administered during Rutukala, which is the post-menstrual phase. It is given after Shodhana, 2-3 Astabana Basti, which helps in better drug absorption as the uterine channels are clear. Procedure. The procedure includes 3 steps: Purva Karma, Pradhana Karma, and Paschat Karma. Purva Karma includes Abhyanga, Svetana, and Yoni Prakshalana. Pradhana Karma includes patient placed in lithotomy position and drug is instilled using an IUI cannula under all aseptic precautions. Paschat Karma, patient is kept in head-low position and monitored for 1 to 2 hours. Mode of action. Uttarabasti works by Vada Shamana, Shodha Shodhana, Garbhashya Shodhana, and improves Artava formation. In modern, locally it improves cervical mucus, enhances endometrial thickness, and helps clear tubal blockage. Systemically, it acts via the hypothalamus pituitary ovarian axis, regulating hormonal balance. Drug selection. In tubal block, we can use Avamark Ksharitaila. In PCOS, we may use Kumari Thaila, and in thin endometrium, Halakrita is very effective. And in hormonal imbalance, Shadavari Krita can be used. Other formulations include Dhanandaran Thaila, Sajaradi Thaila may be widely used. Advantages. Uttarabasti offers targeted drug delivery, faster absorption, cost effectiveness, and minimal side effects. While discussing these, infertility is a multifactorial condition requiring a holistic approach. Uttarabasti acts directly on the uterus, correcting Vata dosha and clearing reproductive channels. It improves endometrial receptivity, tubal patency, and ovulation. Additionally, it has systemic effects through HPO axis modulation. To conclude, Uttarabasti is a key Panchakarma therapy in female infertility. It addresses the root cause by correcting Vata imbalance and improving reproductive function. It is effective in tubal block, anovulation, and endometrial defects. Thus, Uttarabasti can be considered a safe, cost-effective, and promising therapy in the management of female infertility. Thank you.
Thank you, Doctor. Thank you for the well-structured presentation. And next we go to the another paper presentation. I would like to invite Dr. Rinabi S.K. Muhammad for the paper presentation on the topic endometriosis. I would like to invite Dr. Rinabi for the paper presentation.
Good evening to all respected panel members. Today I am going to present my paper presentation topic on endometriosis and Ayurvedic perspective. Endometriosis is a very common yet challenging gynecological condition affecting reproductive age women. Though its presentation, I will explain its modern concept and its Ayurvedic correlation and management. Endometriosis is defined as the presence of functioning endometrial glands and stroma outside the uterine cavity. This ectopic tissue responds to cyclical hormonal changes, causing repeated bleeding, inflammation, fibrosis, and adhesions. It is a chronic estrogen-dependent inflammatory condition commonly seen in reproductive age women. In Ayurveda, there is no single direct term for endometriosis, but it can be correlated with Vatavadashti, Yoni-Vapa, Granthi, and Vataja or Vatikapaja disorder or Vatavaha Stotas. Nidan. Pathological factors can be divided into Ahar and Vihar. Ahar includes Viruddha, excessive ruksha, sheath, food, and Agnimandya leading to hand formation. Vihar includes Viruddha, excessive exercise, night awakening, and stress. All these factors mainly aggravate bath and death and disturbs Ardhava. So Samprati starts with Nidan, leading to Agnimandya and Karma formation. This causes Vata Prakul, which is the main dosh involved. Vata causes remark gaman of Artava comparable to retrograde menstruation. Artava gets deposit in pelvic sides. Kapha and mouse doshi lead to Granthi or cyst formation, which can be compared to endometrium. Pitta association produces inflammation and burning. Finally, Srotodushti in Artava Srotas results in symptoms like Kashtartha, pelvic pain, dyspareunia, and infertility. So dosha strotasa. In this condition, Vata is a chief dosha responsible for pain and abnormal movement. Kapha causes abrasions and cyst formation. Pitta causes inflammation. Doshas involved are rasa, rakta, artha, and mas. The main strotas affected is arthavaha strotas along with rasavaha and raktavaha strotas. Lakshana. The major symptom include severe dysmenorrhea or Kastartha. Chronic pelvic pain is common. This perineumia occurs due to deep pelvic lesions. Infertility or bandhaka is seen in many cases. So there may be also be irregular or heavy menstruation. Chikitsa Siddhant. The main treatment principles are Vatasham because Vat is a chief dosh. So Artava Shodhan and regulation are essential. Granthi Vilayam helps reduce cyst formation. Vedana Shaman provides pain relief. And Rasayan therapy improves fertility and reproductive sperm. Supplementation. For Bharti summoning pain relief, Vajmula quad and eranda tail preparations are useful. Kundavachati Churna helps in Vata Anulaman. For Artava Prasadan, Ashoka Arishta, Kumar Rasa, Kumar Asa, Shatabri, and Navajan preparations are beneficial. For Granthihara action, Panchanar Gugu and Tripura Gugu are commonly used. Shaman, Guruchi, and Musta help reduce inflammation. So, Panchakarma, as mentioned in Charak Samhita, Basti Ravat Haranam Shrestha. So, Basti is the first treatment for Vata disorder. Since endometriosis is the path predominant, so Basti is the main therapy. So, Kashaya Basti helps eliminate the doshas and Anuvasan Basti pacifies the Vata. Upper Basti improve Artavaha Strotas and fertility. Virechan reduces the pitta and inflammation. So endometriosis is a chronic but manageable condition. Ayurveda provides a holistic approach focusing on dosha balance, protoshodhan, and fertility improvement. Early diagnosis and proper management can significantly improve quality of life. So, thank you everyone.
Thank you, Doctor. Thank you for the valuable presentation. And next we go to the another poster presentation. I would like to invite Dr. Samisha Chandrasekhar Charbe for the poster presentation. I would like to invite Dr. Samisha Chandrasekhar for the poster presentation.
On myself, Dr. Samiksha Chandrasekhar Charpe from Prasuti Tantra and Srirog Department from CSMSS Ayurved Mahavidyalaya, Chhatrapati Sambhajinagar. Today I am going to present poster on title Role of Lekan Basti in Management of PCOS, a case study. Guide is Dr. Sanmay Verma, HOD, and principal is Dr. Jayashree Deshmukh Ma'am. I have shared poster as well as PPT for a case study. So, moving to the introduction, symptoms of polycystic ovarian syndrome include amenorrhea or infrequent menstruation, irregular bleeding, infrequent or no ovulation, multiple immature follicles, increased level of androgen, male pattern of baldness or thinning of hair, excess of facial and body hair growth, acne, oily skin or dandruff, dark colored patches of the skin, especially on the neck, groin and underarms, chronic pelvic pain, increased weight or obesity, diabetes, lipid abnormalities and high blood pressure to the patient. Factors causing PCOS are insulin resistance, obesity, and hereditary. Now, we will see the case report. A female patient, 23-year-old, came to the Prasuti Tantra and Srirog OPD of our hospital on 5th March 2025 with the chief complaints of irregular menses, scanty menses, rapid weight gain,
hair loss, and acne on the face from the last 4 years. Her menstrual history. She had her menarche at the age of 13 year. Her LMP was 13th Feb 2025. Interval between two cycles is 16 days. Duration of menses is for 2 days. Pain during menses was moderate and clots are present. Criteria for diagnosis. First one is polycystic ovaries on USG, oligomenorrhea or anovulation, and third one is LH and FSH ratio is greater than 3. The treatment given to the patient is Lekhan Basti. So the drug used in the Lekhan Basti are Madhu, Sendhav, Sneha, Shar, Prakshadravas are Ushakadi Gan, Gomutra, and Trifada. Sneha used was Trifada Tel, Trifada having Haritki, Bibitaki, and Amalki. Ushakadi Gandravas are Kushar, Tuttha, Kasis, Hingu, Sendhav, and Shilajit. And Shar used was Yavak Shar. Treatment is given for the 2 months, and initial assessment is done at the first time. Then after again the assessment was done after 1 month, and lastly result is noticed on 2 months. Signs which are present on initial assessment was delayed menstruation, acne on the face, weight gain, thinning of hair, darkening of skin, and USG report. At initial assessment, menstruation was abnormal, acne on the face is 3 plus, weight was 72, thinning of hair was 2 plus, darkness of skin is 2 plus, and USG report says endometrial thickness was 5.6 mm, right ovary volume 17.1 cc, left ovary volume was 10.7 cc, both ovaries are bulky, right is greater than left. Bilateral polycystic ovarian disease. After 1 month of treatment, menstruation was normal, acne on the face is reduced, weight loss is of weight is 68 kgs, thinning of hair reduced, darkness of skin is also reduced. After 2 months of treatment, menstruation was absolutely normal, acne on the face also reduced to 1 plus, weight was 63 kgs, thinning of hair is also reduced, darkening of skin also gone, and USG report says endometrial thickness of 4 mm, right ovary volume was 10 cc, left ovary volume is 9.6 cc, residual mild changes PCOD. Then discussion. Probable mode of action of drugs. Basti works on the whole body after entering the Pakwashay or Guda. Guda is said as Sharir Mool, having shiras and dhamnis, which spread all over the body. It exerts local as well as systemic efforts. Basti Dravyas normalize the Apanvata, making it to function normal. It also enhances the function of Purish. One of the function of Purish is Anila Anala Dharana. Thus, Basti leads to correction of Agni Dushti. At the end, Basti normalizes the function of Apanvata, leading to the normal Rajapravritti and normal Bijan Nirman. Here, Trifada Taila and Prakshat Dravyas are used in the Basti, and the gunas of Trifada are Balya, Dipan, Pachan, Yoni Vishodhan, Artavjanan, and Bijotsarga. Effect on menstrual irregularities. Pachan, Srotodushti, and Vatstapashamak properties of Trifada and Trifada may be responsible for the efficacy. Ushna, Tikshna, Lekhan, Pachan, etc. properties content of Lekhan Basti are similar to the Pitta. Increases the Agneya Guna of Pitta, which is responsible for decreasing the interval. This effect also supported by Vatanuloman properties of Anuvasan Basti, effect on follicular growth and ovulation. This may be because of removal of Sanga by Kapha Shamaks, Srotodushti, Ampachan, etc. properties of both drugs. After removal of Sanga created by vitiated Vat and Am in Arthabhava Srotas, Apan function well, leading to the normal Rajapravritti and Bijanirman. Thus, it checks the excessive growth and accumulation of Medha Dhatu and thereby causing Lekhan Upashaman of disease.
Now, conclusion. From this case study, polycystic ovarian syndrome patient can manage by Ayurveda treatment. For proper functioning of Arthagara Srotas, balance upon Vayu is needed. Imbalance causes Dushti, that is disease, in the Arthagara Srotas. This is single case study, but large scale study need with the more number of patients of PCOS. Thank you. Thank you so much.
Thank you, doctor. Thank you for the well-explained poster presentation. Next, we go to the another paper presentation. I would like to invite Dr. Poonam Vinayak for the paper presentation. I would like to invite Dr. Poonam Vinayak for the paper presentation.
Hi, this is Dr. Poonam Vinayak Unde, MS Stri Roga and Prasuti Tantra from SSIM Hadapsar Pune, and I'm gonna talk about complete molar pregnancy, that is Draksha Garbha case I have seen in my hospital. So the case was a 20-year-old female, second para actually, with previous 1.5 years old baby boy with her, with amenorrhea of 3 months and 12 days with UPT positive and USG suggestive of complete molar pregnancy with, snowstorm appearance basically. And she had a history of consanguineous marriage, mild pain in abdo and pervaginal PV spotting since 1 week was her chief complaints. Uterus size was of 12 weeks, vitally stable, and HB 12 gram percentage. You can see normal and uterus with molar pregnancy. GTD, that is gestational trophoblastic disease, is a spectrum of abnormal of the growth and proliferation of trophoblasts that continue even beyond the end of pregnancy. Incidence, reportedly the incidence varies worldwide from as low as 23 per 1 lakh pregnancies to as high as 1299 per 1 lakh pregnancies in Indonesia. So types of GTD, we have molar pregnancy, hereditary-form mole or pre-malignant stage, which consists of complete mole, incomplete mole. And the other form is neoplasia or malignancy, which includes invasive mole, choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. Here we go. This table shows the difference between complete and partial mole. The fetus is absent in complete mole and it's partially present in partial mole. We are discussing the case about complete mole, so the fetus wasn't present. The trophoblastic hyperplasia was diffuse and her initial beta HCG levels were greater than 50,000. As you can see in the chart, complications are uncommon. Risk of GTN was 20%. So yeah. Next, clinical features. Vaginal bleeding, excessive uterine growth, hyperemesis gravidarum due to excessive beta HCG levels, hypothyroidism, preeclampsia, embolism of trophoblastic tissue, theca lutein cysts in ovary, which was absent in this case, but it's a significant finding. Okay. Metastatic features depend upon whichever organ is affected in metastasis, whether it is lungs, vagina, CNS, you can correlate with that. Lung metastasis, you can see here. Diagnosis, obviously clinical features. History, physical examination, investigations include beta HCG, very much important, LFTs, RFTs, urine routine, CBC, USG, X-ray, CT scan, HPE, histopath examination. This is the classical snowstorm pattern in USG, as you can see. So GTD staging is described here. Stage 1 if the disease is confined to uterus, stage 2 if it's limited to genital structures, and stage 3 if it's extending to lungs with or without genital tract involvement, and stage 4 if all over metastatic sites. Management of GTD. So hereditary form mole, the principal management is evacuation with serial HCG levels. Here we have done DNA of the patient. So suction evacuation technique we used, as we cannot do harsh curating to the tissue, as it may invade deep, as it is just trauma to the tissue. Serial HCG levels evaluation is the most important point to decide if it's gonna be neoplasia or just normal mole, which we can manage on medications only. Resolution 6 months HCG follow-up is very much important. Another FIGO scoring is given. You can see that. Management of GTN, stage 1 single agent chemotherapy is enough. Stage 2 and 3 includes multiple drug chemotherapy, and stage 4 combination chemo with surgery and radiation and all. Low risk treatment is injection methotrexate. The dosage is 1 mg per kg per day for first, third, fifth, and seventh day, alternatively followed by folinic acid rescue 0.1 mg per kg per day. My patient's weight was around 50 kg, so we adjusted the dose accordingly. Typical side effects were stomatitis, conjunctivitis, abdominal pain, chest pain. This is the most important. You can see day 0 is the day of operative. The beta HCG levels were greater than 50,000 on the day of suction evacuation of the patient. After 48 hours, it were 13,950. Day 7 follow-up 690. Day 14 202. After 1 month, it was 50. After 2 months 10. 3 months 8. Then 4th month 7, 6, 5, 3, 2 up to 10 months. And after 1 year, only 2. That is less than 10, less than 5, which is absolutely normal, and the patient is safe till date. Pregnancy after GTN. Live birth 66.9%, preterm delivery 6.7%, ectopic pregnancy is 1.1%, stillbirths 1.4%, repeat molar pregnancies 1.7% chance is there. This is the HPE histopath report of my patient, which suggests a complete hydatiform mole, and the muscle tissue wasn't included in the sample, so the comment upon invasion hasn't been made, but the patient is safe according to our beta HCG evaluation. Complications include, immediate complications include massive hemorrhage, early onset preeclampsia and eclampsia, hyperemesis gravidarum as due to beta HCG levels were high, pulmonary embolism, uterine perforation, IUGR of viable pregnancy, stillbirth, preterm birth, and remote complications include absolutely choriocarcinoma. Thank you so much. But before I leave, I would like to state on why this happens. The basic question was, so answer is, country that you live in, diet that you take, you must take protein rich diet, and the basic detailed pathology includes the ovum without nucleus or inactive nucleus fertilizes with haploid sperm. So the maternal part is missing from the development of baby, and the paternal part is excess, as you can say, and this concludes in molar pregnancy. That is Draksha Garbha in Ayurveda, as the picture of hydatidiform moles which expelled or evacuated looks like Draksha, the grape-like appearance. This is it. It's Dr. Poonam. Thank you so much.
Thank you, doctor. Thank you for the practical oriented presentation. Thank you so much, doctor. And next we go to the another paper presentation. I would like to invite Dr. Ashikesh Kedarnath Gingade for the paper presentation on the topic anemia in pregnancy. I would like to invite Dr. Ashikesh Kedarnath Gingade for the paper presentation.
Hi, I am Dr. Rushikesh, MS final year student from Swasthyabodha, Maharashtra, Pune, Maharashtra. My topic is on anemia in pregnancy. Start epidemiology. WHO classified the world into the zones according to the prevalence of anemia. High prevalence, more than 30%, medium up to 40%, low up to 15%, not a problem, 5%. Sub-Saharan Africa and Southeast Asia come in high prevalence area. Globally, incidence is about 30%. In developing countries and in India, it is around 40 to 90% compared to 10 to 20% developed countries. A definition. WHO defines anemia in pregnant women, hemoglobin below level than 11 and the hematocrit less than 33%. Center for Disease Control defines anemia as a HB concentration less than 11%. First and third trimester less than 10.5%. And in second trimester also. Degree of anemia according to ACMR. Mild 10 to 10.9, moderate 7 to 9.9, severe 4 to 6.9, very severe less than 5 gram per day. Causes of anemia. Low bioavailability of iron in food, inadequate intake of iron-rich foods, inadequate intake of folate, inadequate intake of vitamin B12, excessive consumption of coffee and tea, chronic infection like malaria and TB, bone infection, menstrual loss of blood, classification of anemia, physiological anemia and pathological anemia, compulsory estimation by assignment hemoglobin method by using semi-auto-analyzer or photocalorimeter at 14 to 16 weeks and 20 to 24 weeks and 26 to 30 weeks and 30 to 34 weeks of pregnancy in all pregnant women. Minimum 4 HB estimation, minimum 4 weeks apart can we do. Downing at 14 to 16 weeks of gestation, second trimester in all pregnant women, single dose of 400 mg of tablet albendazole should be given. Physiological anemia. Pregnancy causes state of plethora. The RBC mass increased by 30%, where plasma volume increased by 40 to 50%, resulting in erythrocyte dilution by 5 to 15% and decrease in hemoglobin concentration by approximately 2 gram per day. The picture of peripherals may remain normocytic, normochromic. The decrease in blood viscosity facilitates better blood flow to the placenta. The increased blood volume also offers productive benefit against blood loss in the first trimester of labor. Pathological anemia, deficiency anemia, iron deficiency 60%, microcytic anemia 10%, dimorphic anemia 30%, protein deficiency, hemorrhagic anemia, acute means blood loss, chronic means profound bleeding causes like hemoglobinopathies like thalassemia, sickle cell anemia, aplastic anemia, anemia of infection, chronic disease like renal, hepatic, diabetic, etc. Effects of anemia on the mother, antepartum complication, abortion, intercurrent infection, preeclampsia, APH, preterm labor, cardiac failure, interpartum, uterine inertia, dysfunctional labor patterns, increased risk of instrumental deliveries, fetal distress, cardiac failure, shock, postpartum effect of anemia, puerperal sepsis, subinnovation of uterus following lactation, puerperal venous thrombosis, pulmonary embolism, cardiac failure, delayed wound healing, effects on fetus, IUGR, prematurity, increased risk of iron deficiency anemia in early infancy, congenital malformation, stillbirth, intrauterine deaths, increased neonatal death, parental mortality rates. Symptoms of anemia. Lack of concentration, infection, palpitation, dizziness, slight headacheedness, irritability, pica, fatigue, weakness, dyspnea on exertion. Signs: failure on mucous membrane or membrane, glossitis and stomatitis, platensia or cholangia, tachycardia, tachypnea, ejection system murmur, ankle edema, increased jugular venous pressure, postural hypotension, work on work of pregnancy with anemia. Detailed history, age, race, parity, dietary habits, history of passing worms in stool, history of bleeding, PR bleeding, hematuria, hyperemesis, malabsorption, chronic disease like TB, etc. Examination. How to examine anemia in pregnancy. Color of mucous membrane, nail weight, splenomegaly, hemolytic anemia, jaundice, hemolytic anemia, purpura, bleeding disorder, leg ulcer, sickle cell anemia, neurological deficit, megaloblastic anemia, anuspara. Approach to a case of anemia. Universal screening for iron deficiency anemia with hemoglobin is recommended for all pregnant first antenatal visit. With the pre-adultum diagnosis of iron deficiency anemia, for trial of a oral iron of for 2 weeks and recommended in patients with mild to moderate anemia. Further administration are guaranteed. If patient does not respond to trial of oral iron, an empirical trial of oral iron for 2 weeks advised up to 30 to 32 weeks of gestation. A patient with mild to moderate anemia is good for consideration. Investigation, severity of anemia, type of anemia, bone marrow activity. Iron requirement in pregnancy. Total iron demand in pregnancy 900 milligram. Uterus means fetus plus placenta 500 to 600 required. Blood loss during delivery 150 to 200. Lactation 150 to 200. Vessel loss 200. Increase HB mass 500 grams. 225 milligram iron is saved as a result of a minor of 9 months. Okay. Average requirement is 4 to 6 milligram per day. 2.5 milligram per day in early pregnancy, 5.5 milligram per day from 20 to 32 weeks, 6 to 8 milligram per day from 32 weeks onwards. Okay. Causes of iron deficiency anemia in pregnancy. Increased demand means 1000 milligram, decrease intake, disturbed metabolism like low erythropoiesis, repeated pregnancies, bleeding plus. Okay. Diagnosis: TIBC raised, RBC protomorphin increase, transferrin receptor increase, serum iron, percentage of saturation less than 16%, ferritin low. Okay. Preventing anemia. To prevent anemia during pregnancy, make sure you get enough iron, eat well balanced meal, and more foods that are higher in iron and to diet. Aim for at least 3 servings a day of iron-rich foods such as lean red meat, poultry and fish, leafy, dark green vegetables, iron-rich cereals, grains, beans, lentils, tofu, nuts, seeds, etc. Thank you.
Thank you, doctor. Thank you for the insightful presentation. As we come to the end of today's session, as we formally conclude today's session of the Swasthyabodha National Seminar presentation, I would like to take this opportunity to express our sincere appreciation to everyone who contributed to the success of this academic gathering. Today's presentations reflected strong scholarly commitment, research orientation, and clinical relevance. The range of topics discussed and the depth of analysis presented demonstrate the evolving academic strength within Ayurveda fraternity. Each presenter approached the platform with professionalism, clarity, and dedication, thereby enhancing the overall academic value of the seminar. We are deeply grateful to our respected panel members for their time, expertise, and meticulous evaluation. Their constructive observation and academic guidance ensured that the standards of this seminar were upheld with integrity and credibility. Their contribution has been instrumental in maintaining the scholarly framework of this program. I would also like to extend our heartfelt thanks to all the presenters for their preparations, punctuality, and professional delivery. Your commitment to knowledge sharing and research presentation is truly commendable. Our sincere gratitude goes to the principals, professors, and academic institutions who supported and encouraged participation in this seminar. Your encouragement and institutional backing have significantly strengthened this initiative. We also acknowledge the dedicated efforts of the organizing committee, coordinators, and technical support team who work diligently behind the scenes to ensure the smooth and systematic conduct of this event. Above all, we thank every participant who joined us and contributed to the academic spirit of Swasthyabodha. Your engagement and cooperation have been invaluable. With profound gratitude to all who stood with us and support this initiative, we hereby bring today's session to a formal close. Thank you once again for your time, cooperation, and scholarly contribution. We look forward to your continued association in our future academic endeavor. And thank you all.